I would like to welcome all of you in our journey in ocular trauma from anterior segment to posterior segment. And first of all, many thanks to our distinguished speaker, Professor Dr. Hassan Mortada from Cairo, Egypt, Professor Ashraf Shaarawy from Alexandria, Egypt, Professor Sangeet Mittal from India, Professor Matteo Forlini from Italy, Professor Ashraf Armia from Cairo, Egypt, Professor Wael Ewais from Cairo, Egypt, Professor Bassem Fayez from Cairo, Egypt, and me, Gergess, and it's an honor to me to moderate this journey. Let us start with some cookies in ocular trauma for decision making, and I would like to make this first sessions in interactive way. So I need the opinion of our distinguished speakers, as well as I will ask the attendee to share with us our opinion. So let us start with the first slides before the big show of our ocular, our videos for ocular trauma. So let us start with this slides when we faced with the patients with ocular trauma with open eye injury. So my questions to the attendee first, and then we will comment with our distinguished speakers. How urgency is the initial surgery in open eye surgery? Let us talk the opinion of our attendee. Is it within 24 hours? Is it within 48 hours? Or within 1 week? Or within 2 weeks? I will post the polling. You can see my screen of polling, yes. Okay, the 96% of our attendee vote within 24 hours. I think all of us accept this. So let us start with Dr. Hassan. What do you think, Dr. Hassan? How the urgency will be in the initial surgery in open eye injury?
I think it should be done, the primary repair should be done as soon as possible, preferably soon after the occurrence of the injury. So within the 24 hours. This is very important to close the globe, maintain the ocular pressure, and as a safeguard against infections. So it should be done as soon as possible.
I think all of us agree this. If anyone has another comment, I think all of us agree this opinion. And the next slides asking about the optimum time for second surgery if needed. If it is immediate, or after 1 week, or after 2 weeks, or after 1 month. Let's start polling from our attendee. This is the initial surgery, sorry, this is poll 2. Yes. Okay. Let us start sharing with our attendee the timing of the second surgery if needed after the primary closure of the penetrating trauma. If it is immediate, after 1 week, after 2 weeks, or after 1 month. Okay, I think the results mainly after 2 weeks, and for myself, I agree this exactly. But I may ask Dr. Ashraf Shaarawy, what's your opinion about the timing of secondary intervention if needed after primary closure of the globe?
Well, there are some indication for early intervention, as if you have an open lens, open capsule, and the lens matter in the anterior chamber. This, if you leave it for 2 weeks, then this would induce secondary glaucoma with all its consequences on the corneal edema and the corneal structure. Again, the old faith that 2 weeks is very important to wait for spontaneous PVD for secondary intervention for vitrectomy is now not very valid, because we have very strong technical tools that helps us to detach the posterior hyaloid and to be sure about that even in young individuals by staining and instrumentation. So we can intervene earlier than 2 weeks other than the old faith. If you see that the eye is quiet, there is no much corneal edema, no secondary glaucoma, then you can intervene even earlier than the 2 weeks.
Dr. Matteo?
Yeah, I agree. Usually it depends on the trauma and depends on the type of surgery. But mostly, in my opinion, after 1 week is indicated for the second surgery.
Okay, Dr. Wael?
Well, I usually try to intervene as early as possible. It may even be done during the primary repair of the ruptured globe. But if I have to wait, I think I wouldn't wait more than 1 week. Because once I have a restored globe integrity by the repair, I can operate on the various pathology that is there, whether in the vitreous or the retina, and to manage the tissue while they are still fresh without developing fibrosis or any proliferative process. I think this helps to intervene as early as possible.
Dr. Hassan?
Yes, I agree with you, but in this specific case, there is a large corneal wound, and my concern is that the corneal wound is not tight enough, and there is not enough time for some coaptation or healing to occur. So my concern is that during secondary intervention, by doing a vitrectomy or whatever, the edges may gap, and so you have to resuture again. So I think within the first 2 weeks, we have to do CT, we have to do ultrasound. Sometimes you do electrophysiologic tests if the vision is poor. And in my opinion, this specific case, the cornea will be clearer, the wound will be more tightly coapted, and 2 weeks I think is a reasonable time, 10 to 10 weeks, 10 to 15 days. I think in this specific case, with no lens and with a large, long corneal wound.
Okay, Dr. Sangeet?
I agree with Dr. Hassan. I think I'll wait for 10 to 15 days just because one, it allows the cornea to get clearer, but in cases if there is a retinal detachment or in ruptured lens, definitely we have to move in early.
Okay, Dr. Ashraf, Armia?
As from the anterior segment point of view, if I don't have a lens capsule opened and have a cataract, I can wait from 2 to 3 weeks until the inflammation subsides and the wound in the cornea getting better. But if there is open anterior capsule and the lens matter is already in the anterior chamber, I'm going to operate within the first week after healing of the inflammation. If it's anterior and posterior and there is a posterior problem, so it will not less within 1 week to 10 days. You should operate.
Dr. Bassem?
I think 2 weeks is ideal for this case to allow good coaptation of the corneal wound and to do further intervention as from my anterior segment point of view. And there is no lens, as you can see from the first picture, so no need for immediate intervention in the second time. So 2 weeks.
Okay.
May I ask you, is this patient is phakic or aphakic, or because
this patient, especially, I will display his video later on in this meeting. But this patient is aphakic, and the lens was removed in primary surgery.
Okay, so I may add that during the primary repair, you have to cut any vitreous incarcerated in the wound,
Sure.
and also remove some of the hemorrhage that may be present, because this because removing this scaffold for proliferation may retard the proliferation of cells into the eye. So the stoke or the incarceration has to be relieved during the primary repair.
Yes. Let's move to the next slide. Do we ask for ultrasound and or CT in the open eye injury from the start? And if so, when? Okay, the result is mandatory in all cases. Let us start again the comment of our speakers. For me, I think it's mandatory, okay, but in open eye injury, the eye usually is soft, and so I usually postpone the ultrasound and satisfied with CT from the start and delayed the request for ultrasound. It is mandatory, yes, but first with ultrasound and then by CT. Let's start with Dr. Hassan.
I think after 1 week, you can perform ultrasound. Of course, CT can be performed earlier, can be performed on the 2nd day or 3rd day of repair of the primary repair, but both should be done. And the operator with the ultrasound is instructed that this is an open globe injury, and he has to be cautious during the procedure. But both should be performed.
Dr. Matteo?
Well, we usually prefer to close immediately the eye before sending the patient to CT scan. Also, sometimes you have to wait for CT scan, so we just close the wound, and then, but it depends, of course, on the situation and the time of the day. Depends how much do we have to wait for the surgery for the surgical room. Anyway, I agree with you about ultrasound. So ultrasound, sometimes we avoid it because if we have open injury, the eye is soft, and so ultrasound cannot be good. But CT scan is very useful, especially detecting presence of intraocular foreign body. So can help. But just for the wound repair, it depends on the situation, because also how much the wound is big. If we have just a small corneal wound, for example, we just can close the eye, of course. But if we suspect intraocular foreign body from the history, we ask for a CT scan, of course.
Okay, let's move. When we order electrophysiology of the eye after ocular trauma, if we no need for it at all or in severe traumatizing eye, let's ask our attendee. When we order electrophysiology of the eye after ocular trauma, if there is no need at all for these tests, or okay, or we request it in severe traumatizing eye only. Okay, and 59% in severe traumatizing eye only, no need in all cases. Let us ask Dr. Ashraf Shaarawy, what's your opinion about this issue?
I think for DRG and VEP, it looks like the certificate of death for the eye. I don't like to order it because it gives a false impression that there is no hope for the surgery. I think the light perception and the light projection and the color discrimination as a clinical tool is much, much more helpful for the decision of surgery. the patient who gets a flat ERG or VAP, nobody would dare to touch him again, although he may have some potentials or hopes for vision restoration after surgery.
Yes, Dr. Wael?
I agree completely with Dr. Ashraf Shaarawy. I don't rely on ERG, VAP, or even the ultrasound in some cases. I think every trauma case deserves a chance to intervene, of course, after detailed, informed consent with the patient. Even if no PL, we have seen some trauma surgeons in the world talking about no light perception cases for whom they operated and they could achieve something. I think we wouldn't rely on ERG or VAP.
Sangeet?
I may do VEP when I'm doubtful of the perception of the light. Sometimes the patient says he is having perception, sometimes he says he's not. But I don't think ERG has got any value in decision making for a trauma case.
Me, I agree too. Yes, Dr. Hassan?
I think it is important in the pediatric age group when the patient cannot tell about his vision, cannot tell whether he's seeing light or cannot see because he is in pain, he's crying. So I think doing ERG and VEP in the pediatric age group, just to know the function of the retina and the optic nerve, I think this may be guiding during the course of treatment. I may add that if the foreign body inside the eye revealed by CT is coupled, this is an indication for very early interference, maybe within few days because of the reaction induced by the coupled foreign bodies. So in trauma, there is no dogma. So we have to adapt our management according to the case.
Yes.
Sangeet.
I agree totally, Dr. Hassan. Yes.
Sangeet, please, can you make the screen full screen, please? Yes, thank you.
In full screen, I couldn't see the. Okay. Okay. If secondary surgery is needed after primary repair and no PL, do you operate? Short questions. I ask the attendee. I noticed that 50-50 around half, okay, around half. No, this is unusual.
Depends on the weight.
Dr. Hassan?
Yes, I think if after the repair, the vision is no perception of light, we may wait for some time and retest the vision. And usually, in some cases, the vision may improve. So instead of no perception of light, after 1 week, there is perception of light, and then there may be hand motion. So I think it is not necessary that if it is no perception of light, that we don't operate. So we have to wait and test the vision again.
I mean, in this questions, if no PL after waiting, after two weeks or more, or I mean, in other words, if I prepared him in the second interventions and I see that the vision is not improving from no PL,
then I will do VEP and ERG.
And if it is subnormal?
Subnormal, then I have to be very conservative. I ask the patient, I let the patient understand the situation and should sign a consent, a heavy consent that the chances are not as when the vision is hand motion or perception with good projection.
When I gave up, Dr. Hassan, in patients with no BL and ERG and VEB, market reduction, showing market reduction.
I may refrain from doing the surgery for medical legal reasons.
Purpose. Yes. Dr. Ashraf?
Yeah.
Dr. Ashraf Shaarawy?
Yeah, for me, at any time, if the vision is no PL, there is no surgery. Because even if the patient is motivated and had a very heavy consent, after surgery, we won't remember this. He will ask for vision.
Okay, if it is not possible to reconstruct the eyeball at all, and enucleation is truly the only option, when do you recommend this vigorous surgery and psychological trauma as well for the patients? Let us see the attendee, the polling of attendee. Immediate, or after 1 week, or after 1 month, or after 2 months. May I ask anterior segment surgeons, Dr. Ashraf Armia, prepare himself, and Dr. Bassem Fayez. Okay, the result is 1 week. The majority, 35%, 1 week. Let's ask Dr. Ashraf Armia.
If the trauma is completely cannot be reconstructed at all, by all means, and I have open uvea and totally eviscerated eye, I will go into inoculated immediately for the fear of the sympathetic ophthalmia. But if I can little bit close the eye till it becoming, I can feel that I can little bit close it. I can wait for a week, then do inoculation. But as early as possible, we should do it for the fear of sympathetic ophthalmia.
Dr. Bassem?
Yes, I totally agree with you, Dr. Ashraf. If the globe can be repaired in the primary situation, I will go to close as much as I can from the globe. Then I will do inoculation if it is severely traumatized for fear of sympathetic ophthalmitis. But if it is non-repairable, I can't repair the globe, it is severely traumatized and the vision is no PL and many content of the eye is out, so I'll go immediately for inoculation to protect the other eye from sympathetic ophthalmitis.
Dr. Sangeet?
First of all, if the globe is not repairable, I will definitely go back to the patient's attendants and patient once again after the surgery is over and then talk to him again that this thing cannot be repaired and there is a chance of sympathetic ophthalmia, but just for the fear of sympathetic ophthalmia, I'm not going to enucleate. I will just wait for some time and see whether the patient develops any kind of visual after maybe just as we talked, sometimes the no PL eyes also turn to PL positive. And then we can again try it and from the surgery once again. But we have to explain to the patient once again and take a proper consent before enucleating the eye. So I'll not go immediately at the same time, but definitely talk to the patient once again and decide whether to enucleate or not.
Okay, let's move to the next slides. Lens removal in surgery with intraocular foreign body. If lens is clear, do you accept removal of the lens if there is intraocular foreign body, if the lens is clear or no? Let us say the opinion of our attendee. Okay, let's ask Dr. Hassan, what is your opinion about the lens removal in case of intraocular foreign body, if the lens is clear?
Well, Magid, it depends on other factors. If the lens is clear, as you said, and the patient is young, and the foreign body is a small foreign body, and there is the detachment, there is no detachment, or there is localized detachment, then I would preserve the lens. But if the lens is clear the foreign body is large or huge foreign body. There is detachment, and there is signs of PVR, and then or retinal incarceration. Then I may think of doing phaco and implanting an IOL in the same during the same procedure. I mean. So it is not. The other factors should be considered.
Okay, Dr. Ashraf Shaarawy.
If there is any opacity in the lens that would jeopardize removal of the intraocular foreign body or fixing of a retinal detachment, I will go ahead and remove the lens. There is no problem in that. Our primary aim is to preserve the posterior segment and to remove the foreign body. What's very critical in intraocular foreign body, usually the foreign body, especially if small, are incarcerated in the area of the pars plana inferiorly at 6 o'clock because of the gravity. And this area sometimes very difficult to reach the foreign body and to handle it efficiently in the presence of the lens. So if this is the case, I would remove the lens even if it's not cataractus. But if it's not coming through the lens and the lens is very clear, especially in young patients, I will preserve it.
Okay, let us start now the route of our journey, which is pole-to-pole surgery in severely traumatizing eye from penetrating ocular trauma causing severe damage from the cornea to the retina. And the challenge in this situation will be great and double in the anterior and posterior segment as well. Dr. Matteo accepts this challenge and will show us the tour route and how he managed this severely traumatizing eye. So can I ask Dr. Matteo to share with us your experience?
Okay, thank you again for this opportunity. So I will show you my 3 cases. So I have 3 cases to present you with the pole-to-pole approach in different severe traumas. So I'm sharing desktop. Okay. So my first case is a 38 years old male. He had a traumatic subluxated cataract with zonulodialysis and mydriasis. As you can see, this is the pre-op situation. And you can see here that was the beginning. So total large subluxation of the cataract of the crystalline lens and mydriasis. So the first surgery was phaco, and I just removed all the lens because the capsular bag was too damaged. So I couldn't use the capsular bag to implant the IOL. So I just removed all the capsular bag, and I tried to do a Slipser sliding knob technique, but it was impossible because the mydriasis was very old. Actually, this patient received the trauma 30 years before, when he was a kid, when he was 13 years old. Now he's 38 years old. So the reason, I don't know why he didn't have surgery when he was a kid, but after 30 years, the iris became rigid, became inelastic, so the iris became impossible to treat, to stretch. And so I tried to do iridoplasty, but the iris tissue was so rigid, so fibrotic.
Dr. Matteo, yeah? Dr. Matteo, this is the next stop. We are now asking you about the temporary keratoprocesis and trauma from the cornea to the retina.
Okay. So another case. So sorry.
Yeah, no problem.
Okay. Sorry. So that was my second case. Okay. So this is another case, pole-to-pole surgery. So 50 years old male. He presented like this, corneal wound with post-traumatic anuridia and aphakia. So, okay, first time surgery, corneal suture, immediate, of course. But after 1 week, we did the second time surgery. So PK, penetrating keratoplasty and vitrectomy using temporary keratoprosthesis, and vitrectomy because we also had the luxated lens in vitreous chamber. But the retina was flat. And the third time surgery, I will show you later, artificial iris implantation with IOL included, with scleral fixation. So, video. So this is the approach. You see the cornea after the corneal wound repair. So we prepare for the PK. So of course we have to remove the cornea because cornea was too damaged. And so this is penetrating keratoplasty. And now I am using the temporary keratoprosthesis by Eckert. You see, this is the TKP. And now I'm suturing, of course, the TKP to the sclera. And so I'm ready for the vitrectomy. I'm using 23 gauge vitrectomy. And you can see the lens dropped in the vitreous chamber. I am using triamcinolone, of course, to stay in the vitreous. So with triamcinolone, I can see all the vitreous much better. And now I'm focusing on the crystalline lens to remove the dropped lens. So little by little, with the vitrectom, I repeat, I'm using 23 gauge vitrectom. So the lens, fortunately, was quite soft, so I can eat only by vitrectom. So little by little, I can remove all the lens material. That's it. So now I'm doing indentation just to check the retina, and I want to do complete vitrectomy with the peripheral shaving. So we know that it's very important in trauma cases to remove all the vitreous, even in the extreme periphery. You see some blood clots, of course, but the good point was that the retina was flat. So the patient was quite lucky because he didn't have retinal detachment. So I'm just completing the peripheral shaving, 360 degrees. And now when I finish the peripheral shaving and extreme peripheral vitrectomy, I'm just proceed with the endolaser. In these cases, of course, I always do 360 laser, prophylactic, of course, but also you never know. In trauma, you never know. Maybe you can have a small hole, you can have a small retinal hole in the periphery. So always 360 degrees of laser. And now the final graft to complete the penetrating keratoplasty. So the situation, the final result was good. The retina flat, corneal graft is positioned. And of course, the patient now is aphakic. So the patient is aphakic and anuridic. So complete aniridia and aphakia. This is the final result of the surgery. But after 4 months, we went back to operating room to implant the artificial iris prosthesis by Rapper. This is the most recent artificial iris prosthesis. Rapper is a Russian company. And the prosthesis is very good because the IOL is included in the artificial iris prosthesis. So I'm preparing for the scleral fixation, 3 points, 12 o'clock, 4 o'clock, 8 o'clock. And you can see the artificial iris with the IOL included in the center. I'm using Prolene 10-0. And now I'm just reopening the corneal suture because I did this surgery only 4 months later from the previous penetrating keratoplasty. So the corneal suture was still fresh, and the corneal scar was fresh. So it was very easy. It was very easy to reopen the corneal wound of the graft. And now I'm implanting the artificial iris with scleral fixation. It's very important to find the good positioning. And now I am just putting again the corneal suture in the same place, on the same line of the previous corneal graft. And I'm just closing now the scleral fixation. You can see it's very important to obtain a good centration of the pupil. And that's it. This prosthesis is very nice because you can order the good color, the color of the patient, and the good IOL power using standard IOL calculation with the IOL master. And now I'm just closing the conjunctiva, and this is the final result of the third surgery. So now the patient is with IOL and with iris again. And 12 months later, 1 year later, this is the situation. So the corneal graft is still good, transparent. IOL is centered, iris is centered, and patient is happy. Thank you.
Thank you, Dr. Matteo, for very nice presentations. And to see or not to see, this is the value of the first stop in our journey, which is the cornea. That may be affected in severely traumatized. And its management is essential in treating what is behind. So, Dr. Hassan, can you show us the challenge in the treatment in such situation with cloudy cornea and posterior segment problem, please?
Okay. Okay, Magid, can you see my screen?
Yes.
Yes.
Okay. Thank you, Magid, for the opportunity, and I'm really happy to join this group of distinguished vitreoretinal surgeons, highly specialized in doing trauma cases. This is an 18-year-old male who presented with severe corneoscleral injury with a cutter. The injury did not involve the eye only, but also it involved the lids and part of his lips. Primary repair was done by doing vitrectomy and silicone oil injection, and at that time, the clarity of the cornea could allow doing the surgery even from a small part of clear cornea. The patient developed total retinal detachment recurrent, vitreoretinal incarceration, and extensive subretinal proliferation. And in this, I really operate on this patient maybe 3 times. And in the last operation, this was the picture. The cornea was opaque in the most part, severely vascularized, superficial and deep, and stromal vascularization, and the vision was hand motion. This is the picture at the time of surgery. So you can see that the cornea is thickened, edematous, opaque, and the corneoscleral wound really involved as if it is transversing the globe. And this is a retrocorneal membrane, and then the same type of temporary keratoprothesis as Matteo was using. Epiretinal membranes were removed. There was a severe PVR retinal shortening, and extensive subretinal proliferation. The epiretinal membranes were removed, and then I have to remove the subretinal proliferation, which were extensive. So retinotomy was performed. And I know that doing retinotomy in these cases maybe increase the chance for reproliferation, but this was the only way for repairing this retina, and using the bimanual technique with 2 forceps, 1 hand over hand technique, pushing the retina, trying to get the subretinal proliferation out. And you will see now how huge was the subretinal proliferation. And this may be related to cutting in the dangerous zone of the ciliary body. The injury was involving this area. There was some retinal rotation that was corrected. There was escape of some PFCL under the retina that was removed. And then the retina was attached with PFCL. Endolaser was injected. Then I thought of resuturing the graft of the patient, because silicone oil was inside the eye, and I would not risking a graft, putting a clear graft in this patient. And later on, the patient underwent another surgery for the removal of epiretinal proliferation and implanting a clear graft. The problem in these cases is that it is not only a problem of the retina, but it is also a problem of the cornea. So even if you solve the problem of the retina, which is also difficult, the problem of the cornea is another big problem, because these eyes are prone to develop clouding of the graft. So the patient should be prepared that he may need more than surgery, maybe 3 or 4 surgeries until the stabilization of the proliferative process and treatment of the corneal pathology. Thank you.
Thank you, Dr. Hassan. The cloudiness in previously traumatizing eye add more challenges in treating retinal detachment. So Dr. Matteo will show us the tips and tricks in retinal detachment surgery through previously traumatic cloudy cornea. Dr. Matteo?
Yeah. So this is I called it cloudy with the chance of retinal detachment, like cloudy with the chance of meatballs. This is my child, my daughter Ginevra favorite cartoon, so I know it very well. So what to do when cornea is cloudy, when cornea is very opaque with the corneal scar. So in this case, for example, I want to show you this situation, because sometimes we can have a big corneal scar, but we can avoid the corneal transplantation. So we can do the vitrectomy without removing the cornea, so without using temporary keratoprosthesis. And of course, for the patient, of course, it's better to avoid the penetrating keratoplasty. So this is an example when we have, of course, we have a big corneal wound, we have a big corneal scar, but we can avoid the penetrating keratoplasty. So in this case, we also have iris laceration, aphakia, retinal detachment, and traumatic full thickness macular hole stage 4. So I just positioned the 3 trocars, 23 gauge trocars, and I just positioned the chandelier 27 gauge. So let's see. We go inside, and I'm using Biome. Biome is a very useful instrumentation to see wide angle viewing system. And now I'm injecting triamcinolone. I can see the vitreous very well, and you can see posterior vitreous detachment. This is a young patient. He was 30 years old, so No, it was less, 25 years old, so even younger. And you can see the posterior vitreous detachment is very clear, very nice to see it with triamcinolone. So after posterior vitreous detachment induction, I'm injecting PFCL, but you can see now there's a problem because a corneal stitch ruptured. So I have to stop and I have to go back to, I have to go to anterior segment to do again some corneal suture because the corneal stitches broke. So after a new corneal suture, I go back to posterior chamber, to the vitreous chamber, and I have PFCL on the posterior pole. Now I'm doing peripheral retinotomy because, as I told you, I had retinal detachment with macula hole, but I had no retinal tear in the periphery. So I just did one peripheric retinotomy just to do the drainage of the subretinal fluid. So now with this retinotomy, I did complete drainage of subretinal fluid. Now retina is flat. I found a small intraocular foreign body. This intraocular foreign body was in the periphery of the retina. So I just removed it. Probably it was a piece of glasses. And now I'm completing with endolaser. And now I'm doing the iridoplasty to create a better iris shape. You see there is this iris rupture, and I'm preparing for the IOL. I'm using iris claw IOL, so iris fixation on the posterior surface of the iris. So this is posterior enclavation of the iris claw on the posterior surface of the iris. So this is a retropupillary iris claw enclavation. After opening the cornea at 5.5 millimeters. And then, of course, I'm closing the corneal wound. Usually with 3 corneal stitches is enough. And now I'm going back to posterior, to the vitreous chamber to do the gas exchange. I use C3F8 gas, not pure gas. I'm using the 15%. And now I'm doing the fluid, the perfluoro PFCL gas exchange, and this is the final result. So you see that I did all the procedure, even if the cornea was damaged. 2 months later, and also I put at the end I put Densiron. I put Densiron at the end. Sorry, no gas. I was sorry. And now 2 months later, I removed the Densiron. I just removed the Densiron, and now I just put the final gas. And now I put the silicone 5,000 centistock because actually I was thinking to tamponade with gas, but I prefer to leave the 5,000 centistock silicone oil because in these cases I always have fear of redetachment. And so actually this is a question that I ask to you. How do you behave with the traumatic retinal detachment? In my experience, sometimes I did with gas tamponade, and everything was good for 1 month, but maybe after 1 month or 2 months, the retina redetached in traumatic retinal detachment. So now, in my experience, I prefer to tamponade with the silicone oil. Anyway, I just show you the follow-up, 6 months follow-up. You see the IOP is good. The visual acuity is 0.3. And then after 18 months, visual acuity also is 0.3 and intraocular pressure is 15, is good. But the cornea is still good. Cornea is still, okay, you see the big corneal scar, but the cornea is still transparent. This is OCT, so macular hole is closed, and you see the macula now is okay. So macular hole is completely closed. And this is the fundus with the silicone oil inside. This is endothelium. And this is the anterior OCT showing the corneal scar again. So this is now the patient after 18 months follow-up. You see, the cornea feels transparent. So this is my take-home message is that using chandelier, using bimanual maneuvers, using glucose gel can help you during the surgery to get a better visualization on the cornea, of course. And biome is perfect in these cases to obtain a big wide-angle viewing system. So thanks to the use of chandelier lights and wide-angle viewing system, you can manage cases through a cloudy cornea with poor fundus visualization. Thank you again.
Okay, let's now move to the second stop of our journey, which is the iris and its gate. Of course, this is the pupil. As you all know, marked photophobia and blurring of vision may occur from aniridia or even traumatic mydriasis. And the management of these and management of these two difficult situations are also challenged. So Dr. Ashraf, Armia, tell us how to manage this traumatic mydriasis of the pupil.
Thank you, Magid, for the invitation and to be among all these eminent anterior and posterior segment surgeon. So I have no financial disclosure regarding my presentation. In this case, it's a female patient, 58 years old, done phaco elsewhere since 10 months with dilated fixed pupil. Was before the operation, but the surgeon didn't do anything due to the older trauma. I found that her refraction has a refraction error of minus 2.25 sphere and also 1.75 astigmatism. She is unsatisfied and becoming crazy with exposure to light. Plus, it's a light iris patient. So I told the patient the only solution that we can start dealing with the dilemma by creating a nearly round 4 millimeter pupil. So this is my technique in this traumatic mydriasis. I call it 2-1-4. It's 2 paracentesis to the right and 1 paracentesis to the left. Injecting visco-dispersive. Then very important in these long terms that you stretch the iris very well. Don't try to do pupiloplasty without good stretching of the iris because there is a retro inversion of the iris. The iris is rolled in. So when you catch the iris and take the snap in the iris, you take the edge of the iris, not the rolled in iris. It's called the retroversion. First, suture is very important because it is the guide to the center of the pupil, because you cannot know where the center of the pupil in these cases. I use the force-through pupiloplasty, which is innovation from Ammara and Priya. It makes the iris surgery very easy by 1 knot. So it's called, my technique is 2-1-4, is 2-2-1, and 4 is a 4-through pupiloplasty. The first knot is very important. Don't take the other side, the same side, unless you take the other side, because with the second suture, you are going to see where is the center of the pupil now. 4 through, that you make 4 through, and with simple knot, you don't do just 1 knot. With the 4 through, you can close the iris. So now you are creating nearly the center of the pupil. You take another one in the first side to close any still part of the iris not closed with the same suture. So you take 4 sutures, two in each side, with this simple technique, which is the 4-through pupilloplasty. And the other side. So you're changing the patient's refraction also, which we are going to see now, because you do another optical position that you make, it's like pinhole pupilloplasty. You changing the optics of the patient also. Instead of the refraction of the patient was not good, the refraction of the patient was going to change without even changing the IOL position. So after I finish this, you wash the visco, dispersive. And this is the patient post-op. The vision changes from 220, 280 to 2040. And the patient is satisfied with her vision. Thank you so much.
Thank you, Ashraf. Dr. Matteo, you have a different way in management of traumatic mydriasis associated, especially if associated with lens subluxation. May I ask you to show us your technique in management of this traumatic mydriasis with lens subluxation?
Yeah. Yeah. So this is the case of this subluxated cataract and xenologue dialysis and big mydriasis. But this is a special case because the mydriasis was very old. This trauma was of 30 years before, when this guy was a kid of 10 years old. So after all this time, the iris became rigid, inelastic, and it was very hard to obtain a good iridoplasty. It was impossible. So I just want to show you how I managed to try to
But you did not share the screen.
Yeah, no, because I was just prepared this. Okay. Okay, I just prepared the one with the no, I can. Okay. I just want to show you this one because it was difficult. It was almost impossible to find to obtain iridoplasty. This one. This is it. Okay. So usually the iris is elastic, but now I'm trying to do the phaco to remove the capsule. So I'm doing a normal capsulorhexis. I'm trying. It's just an
Share screen, Dr. Matteo. Please share screen.
The screen?
Yes, we.
Okay. Okay. Sorry.
We couldn't see you.
Sorry. Okay. Sorry. Now.
Yes.
Yeah. Okay. Sorry. Now you can see.
Yes.
Okay. So I'm doing. I'm trying to do a phaco because this is extremely subluxated cataract, traumatic. So I'm doing a capsulorhexis after trypan blue staining, of course. And this is quite difficult, but using forceps and scissors, I try to obtain quite quite regular capsulorhexis. Now I'm completing the capsulorhexis, and now I'm doing hydrodissection. So the lens is very soft. Lens is very soft, very easy to remove, of course. This patient is young, but now I can see that the capsular bag is very, very subluxated. The zonal dialysis is too big, and even if I'm trying, I'm finishing my takeoff, but it's almost it's difficult to keep the bag. And actually, I didn't have a Sioni ring. Maybe in this case, the Sioni ring was the good solution, but I didn't have Sioni ring, and so I just prefer to remove. This is finished. The cortical remnants are removed. The cortex is removed. I prefer at the end to remove the capsular bag because it was very subluxated, and I cannot use this capsular bag. So I just prefer to remove completely the capsular bag to obtain a complete aphakia now without capsular bag remnants. I'm doing anterior vitrectomy. I'm doing anterior vitrectomy, and I also injected. Now this is anterior chamber maintainer. For the pupilloplasty, but in this case was impossible because the iris tissue was fibrotic, was very rigid, was completely unelastic. So as you can see, I tried again, but it didn't work. Also, I was doing damage. So in this case, I just it's impossible. So I just do the last attempt using. The normal Sipser sliding knot technique, Forlini zero suture, and now I'm pulling the suture, but you see the iris tissue is not elastic at all. So you see the iris is breaking. The iris is breaking. So I just realized that it was not possible to suture. This is just an attempt. It's just trying to do, you know, it's impossible. So I'm creating an iridodialysis. So I just stopped. It was not possible to proceed, and so I just said, okay, not possible to do iridoplasty because the iris is too rigid. The trauma was too old. It was 30 years before. So,
intanto facciamo una carrellata sulle nuove sale. Allora, Matteo Forlini.
So I just did the second surgery, and this was the artificial iris implantation. Actually, I did that in live surgery in December in Italy. There was the
Aniridì o qualcosa di simile?
The National Congress, and this is the artificial iris implantation. So I ordered again a wrapper prosthesis. Because this was during live surgery, so there are other surgeons operating at that time. Oh, sorry. I just want to go on because time is finishing. Okay, so I'm doing the scleral flaps, you see. I'm just going fast. Anterior chamber maintainer, and again, this is the artificial iris. This was the previous case, you see. So this was the images that I showed you. And now this is the solution. Artificial iris with scleral fixation. Again, as I showed you before, this is 10-0 Prolin. And using the scleral fixation, this is the positioning. So in this case, when the iris is very rigid and the midriasis is very old, very fixed, so the midriasis usually is good for iridoplasty with pupilloplastic technique like Sipser slide and knot technique. But when you have a very old trauma with artificial iris, with the iris very rigid and fibrotic, the only solution is artificial iris, like in this case. So this is the end of the case, and you see now I'm just completing the centering of the artificial iris prosthesis again. And in these cases, I always use the anterior chamber maintainer because, okay, another option is to use the viscoelastic, but you should use a lot of viscoelastic because the viscoelastic always goes out from the anterior chamber and you don't have the control of the intraocular pressure. So I prefer using anterior chamber maintainer always in these cases of big trauma surgeries. So this is the last suture, and this is it. I know that other colleagues prefer to use the viscoelastic, but another reason to use anterior chamber maintainer is to contrast the hemorrhage, because if you have some hemorrhages, the anterior chamber maintainer can stop the hemorrhages. But if you're using viscoelastic and if you have hemorrhage, viscoelastic is not so good if you have hemorrhages. So I prefer always anterior chamber maintainer in this kind of complex surgeries. And this is the final result. So 5 months later, this is the result. The cornea is transparent and the artificial iris is well centered. Thank you.
Thank you, Matteo. Management of traumatic aniridia is not that easy, as it is a challenging procedure, especially in aphakic eyes, to implant huge optic with iris pattern. So, Dr. Sangeet, kindly show us how to manage this case of aniridia, please.
Thank you, Dr. Majid, for giving me this opportunity. So I'll just present my technique of managing aniridia. I use an aniridia IOL, and my preferred technique is the hangback technique. So I'll be showing one case of this technique. This is a 53 years female who had a post-traumatic aniridia, and she had undergone vitrectomy for a vitreous hemorrhage plus RD earlier, and now she was now being treated for aniridia. So this is my technique. I think the audio is embedded in this. So first we, sorry.
Dr. Sangeet, the voice of your videos overlap your voice.
Okay, I think can I mute the video?
Yes, please. Yes, you can explain now.
Right. Is it muted now?
Yes.
Okay. I make a, I think there is some,
We couldn't hear you, Sangeet.
so now I make these sclerotomy, I put these cannulas, and after this sclerotomy are made, I take this NIDDA IOL, which is available in India, and through these loops of these haptic loops, I pass the 10-0 proline suture, and then I bring this suture out from this inferior sclerotomy on one side, and the other end of the suture is brought to the superior sclerotomy on the same side. And this procedure is repeated on the contralateral side. So once when all these four ends are out, I insert the IOL inside and then remove these cannulas, leaving the sutures behind. Then the IOL is centered and these sutures are tied by giving a 3-to-1 knot. And this knot is then buried inside these sclerotomies. And both the sclerotomies are, both the knots on both the sides have to be moved in different directions to center the IOL. After this, the incision is sutured and the conjunctiva is sutured. And this is 1 month post-op. The best corrected vision was 6/6 in this eye. So this is how I usually manage a patient of traumatic NIDDA.
Okay, thank you, Sangeet. Anaridia also is a big problem if associated with traumatic retinal.
The voice is not coming, Dr. Majid.
Okay. Anaridia also is a big problem if associated with traumatic retinal detachment in aphakic eyes due to lack of compartments of the globe. There is no barrier between anterior segment and posterior segment as well, making it a blending agent like silicone oil in contact with back surface of the cornea, with resultant possible decompensation and intractable glaucoma may be the results. So let us see you this interesting case. This is a case of traumatic retinal detachment in congenital aniridia. Cataract extraction was performed 17 years before, and the patient has Salzmann nodular regenerations in the mid-periphery of the cornea, make the visibility to some extent hard to do vitrectomy. I did vitrectomy surgery routinely as if I did in rhegmatogenous retinal detachments, peeling of the posterior hyaloid, shaving of the vitreous base, and now I decided to do a barrier between the anterior segment and the posterior segment using a meshwork or a mesh from the Porlini 10-0. Using 2 arms of Porlini perpendicular to each other, making a mesh, and the bore of the mesh prevent the migration of any silicone oil to the anterior segment because the buoyancy of the silicone oil prevent its migration from this pore. And then I went back to the posterior segments to complete my vitrectomy surgery, doing drainage retinotomy because I couldn't find the tear in this peripheral opaque cornea. We can see nicely the reflex of the mesh against the air, and finally the silicone oil was injected, leaving a small bubble in the anterior segment. This is the post-operative picture after a few days from the primary surgery, and after 3 months I decided to remove the silicone oil as well as I removed the mesh of the threads of the Porlini, and I removed the mesh. And at the same time, our consultants in our hospital, Professor Fathi Fawzi, decided to do the iris IOL, which is morsure IOL, but this technique is different from our colleague Sangeet because he did scleral tunnel, not scleral tunnel, Hoffman pockets, and then implant this iris, the aniridia IOL. And this is the final picture. The vision in this case improved to 0.16 from hand motions during detachment, in case of traumatic detachment. So the next stop in our journey is the lens, whether crystalline lens or IOL. Let us see how lens abluxation, whether crystalline lens or IOL, as this may need a lot of a challenge to preventing it from invading the posterior segment and cause any damage. Let us see this challenge with Dr. Ashraf Armia in his case of zonular dehiscence after ocular trauma. Please, Ashraf.
This case came to me for a cataract surgery. She was a female patient, 65 years old. History of drop of vision was gradually after trauma since 5 years. But on examination, I saw a weird shape of dense posterior subcapsular cataract in one side of the lens. The other side was not too much cataractus. With radial shape, cortical cataract was seen. This is the picture. So there is a posterior subcapsular cataract. There is a weird cataract in this side, and there is a track like this. So before I start the operation, I was planning, and on the slit lamp, I didn't see any subluxation. But my decision during the surgery to plan everything possible tool with me for any problem can happen. So, as I started the operation, I did visco-cohesive. Then, very important, see, as you see this, this sign, very important to watch. When this happened, this wrinkling, this is the first sign you should notice in any traumatic cataract. That means that this side is not, the zonules are not okay and the other side is okay. So I continued the Rexus. It was not a problem for me. It was okay. Then, as I am doing the rotation of the lens, another problem, another sign appeared. This, that I feel that the zonulosis is starting to be more clear to me. So at this position, you should stop and think what to do to complete your cataract traumatic case safely. So I took the decision to use the capsular hooks, and I put it at the two sides of the two zonulosis parts. So I take the fluid of the phaco in between, and these are supporting the 2 points. So I continue the phaco because it was a grade 3 cataract, it was not soft cataract. When I divide against the part of the zonulosis, very important. And you are going to see how the rexus and the bag is stable by using these capsular hooks. They are making the operation safe for me and making a chance for me to implant safely inside the bag. After you finish your phaco cataract as usual, very important, don't remove your capsular hooks in this position. And this is the modified capsular hooks from MST. This is the last version, very small, does not interfere. Very important before you remove your phaco in these cases to maintain your intraocular pressure with a visco-dispersive OVD. Don't go out and leave the IOP lost. Very important not to increase the zonulosis. At this site, you should put your CTR. Don't remove these capsules before you put your CTR. And I use the modified CTR in case I felt in the bag it was not okay, I'm going to suture. But this is, I didn't need this because the bag was stable. I implanted and then did the phaco, and safely from traumatic zonulosis, I could save the bag because I noticed the problem early. So always I say 2 signs very important in traumatic cases: early to watch and to notice. It is safely that you save your bag for a good implantation inside the bag.
Okay, if subluxation is massive and associated with undilatable pupil, it will add more challenge to overcome these difficulties and avoid any damage to anterior and posterior segment as well. So Dr. Bassem, let us see how to overcome these difficulties.
Okay, thank you, Dr. Magid, for your kind invitation, and thank you, Eva Pharma. I'm going to share my screen. Okay, this is a case of 68 years old male who had blunt trauma by stone 2 weeks ago. On examination, the visual acuity was hand motion with good projection. The iris was tremulous, irregular depth of the anterior chamber. Because of his age, the pupil was not dilatable, and it's grade 4 or 5 brown nuclear cataract, and the B scan was non-remarkable. So I planned to do phaco and to use the Sione ring and implant in the sulcus. Now creation of 2 Hoffman pockets. Then to dilate the pupil, I used the Malyugin ring insertion. It was a little bit difficult because of the iridodenesis, and I have no support with the iris, with the lens, but I succeeded to put it, and I achieved a good dilatation of the pupil. Then in these cases, I prefer to start the Rexes by 27 gauge insulin needle. You can see the corrugation in the anterior lens capsule, as Dr. Ashraf told us. Then after completing about half of the capsule Rexes, you can see that the lens is moving in all directions. I decided to use the first capsule hook just to help me and act as a third hand to complete the capsule Rexes. Now the Rexes is completed, and I will I will use 2 more capsule hooks. You can use a second instrument to aid you to implant it, to fix it in the back. Now hydrodissection, and you can see how hard in the cataract here. The bag is stable because of the capsule hooks. Now you can do, I prefer to do stop and chop technique, phaco. Everything is crowded in the anterior chamber because of the pupil. Now more rotation of the lens to get it by chopping technique. The bag capsule is redundant. The lens is very huge, as you can see here. But thank you to the capsule hooks who helped me to complete the case. Then I put more and more methyl just to protect the endothelium and to have good depth of the anterior chamber. Then completing the rest of the nucleus and preparing the bag for implantation, then irrigation, aspiration of the cortical matter. But sometimes things don't go the way you expect. Oh my God, there is a tear in the posterior capsule. So I removed the hooks. Then you can see here the large capsular tear in the posterior capsule, then removal of these instruments, then tamponading the vitreous by viscoat, and then doing anterior vitrectomy and removal of these residual lens matter from the anterior chamber. More and more anterior vitrectomy and removal of the whole capsular bag. Then by the aid of triamcinolone to make sure that there is no vitreous in the anterior chamber. And now my plan was changed to implant a retropupillary verisize, as Dr. Forlini showed us. Easily you can implant it. It's very easy and very stable. And finally, I closed the wound by 10 nylon suture, and this was the final picture of the case.
Okay, fibrotic anterior capsule is a late traumatic cataract development. Add more difficulties and challenge as well. So, Dr. Ashraf, can you show us your case in this difficult situation?
Yes, Maggie. This was a case of a child, 15 years old. He has a history of right eye blunt trauma since 5 years. And he developed severe ocular inflammation following the trauma, ending by formation of white patchy membranes on the iris and the anterior surface of the lens, with 2 areas of peripheral anterior synechiae. complicated white cataract also developed. The vision was hand motion, good projection, good macular function. The intraocular pressure was 16 millimeter mercury, and the retina was in place by ultrasound. So, this was the case. This is the picture. This is a white membranes and membranes over the lens. And only this part is clearly seen. So my opinion in these cases, or my plan, it was to find where is I'm going to remove the membrane, because I know that this membrane in this side, it cannot be removed because it's totally amalgamated with the iris. Any intervention for this, we are going to lose the iris tissue. So with the visco-dispersive and visco-cohesive, high visco to protect the cornea in these cases because of the inflammation happened, the endothelium is not, definitely is not good. I'm trying to see where I am going to stop. With the micro scissor, I'm trying to find a plane between this membrane and the anterior surface of the lens without opening the anterior capsule, which is a very mandatory. I need to end the case in a very nice way. So slowly with the micro scissors from both sides, taking the edge of the old iris, removing the membranes here, then I'm doing staining of the capsule. In this stage, I used the Malugin ring, which is out of label to use in these fibrotic parts. It was not an easy to implant the Malugin ring. It was okay here, but this side, it was very difficult. It took a lot of time because the thickness was thickened. Very important in these cases to do a proper good size rhexis, because this is a child and the eye is inflamed, not to have another adhesion between the inflammatory iris and the capsule. So I remove the cataract. Then I'm planting a single piece, removing the Malugin ring. But I did here also, after some snips to decrease the inflammation post-operatively, not to close up it. So the eye changed it from hand motion to 20/80 post-operatively, and this is how I did the case.
Thank you, Ashraf. Dr. Sangeet has a video of subluxated one-piece lens and will show us how small incision can be made to remove this IOL. Dr. Sangeet?
Thank you, Dr. Majid. I'll just share this case. This was a post-traumatic IOL subluxation. The patient also had a vitreous hemorrhage, and we did the vitrectomy also in the same sitting, but I'll just focus on the removal of the lens in this patient. So this was the patient. He had a post-traumatic IOL subluxation. So we went ahead with a 3 to 3.5 millimeters of fluorocanal tunnel incision. And then the lens was separated from the vitreous. The lens was hooked from the haptic by one of the hooks, and the cutter was used to separate the lens. The incision was then opened, good viscoelastic coating was done. One haptic was prolapsed out of this small incision. The inner part of this haptic was cut because I wanted to have a good hold. Now I'm using this McPherson forceps and holding the IOL from the edge. Now take a spatula or a hook above the lens and then just bending the forceps anti-clockwise. You just bend it anti-clockwise and the IOL folds itself. And once it is around 180 degrees folded, then you can just pull this lens out from this 3 to 3.5 millimeter incision. So just did it recently and wanted to share this case. Thank you.
Thank you, Dr. Sangeet. Management of traumatic subluxation of retrobabellar versailles is not that easy also in all cases. And I will show two cases of different managements. This is a case of traumatic subluxation of one side of retrobabellar versailles. This case I did for him vitrectomy 2 years before and silicone oil injection, and I implant the retrobabellar versailles during silicone oil removal. And after trauma, as we see, I support the side of attached versailles by a light pipe, and on the opposite side through the sideboard, I do inclinations. Just a few minutes, I finalize my job and close the eye, and the operation is finished. But in not all cases looks like these cases, and not all cases are simply easy. This is other case of the same scenario as well, trauma, dropping visions, past history of vitrectomy. I did 2 years or more before, traumatic subluxation of one side. I tried to do the same technique and try to do incubation away from the area of previous incubations, but the IOL is floating because the two lines of incubation are not on the same line. So the versailles are mobiles, and all of a sudden it falls down back to rest on the posterior segment. So I catch it and grasp the versailles, deliver it in the anterior segments, and I do a scleral tunnel. I usually do, and I usually like the incisions of a scleral tunnel. I do round incision and deal with this IOL as if it is I implanted for the first time. Put the two haptics behind the IOL, obliquely, not horizontal like previous, and do inclinations like oblique away from the previous inclination site. And finally, I close the wound by just one suture of Vecril 80. So, Dr. Bassem, in case of recurrent decentered three-piece IOL after being reposited following trauma in primary surgery, do you remove it, replace it, or doing another trial of fixation?
Okay, this is a 58 years old female who had decentered sulcus three-piece IOL after blunt trauma 2 months ago. First recentration with optic capture I did 6 weeks after the trauma, but unfortunately 2 weeks later the IOL was decentered again. So in this video you can notice the decentration of the IOL and the size of the pupil is mid-dilated, now delivering just the optic in the anterior chamber to make pupillary capture. And then I decided to fixate the same IOL with the aid of 9-0 Prolene suture by, as Dr. Ashraf said to us, by single pass force-through technique to fixate this lens again to avoid many or future recentration again. The same was done with the superior and inferior haptics. This is a 4 path. You have to do it you enter in this loop 4 times. First one, then the second one. Because of the viscoelastic, it was a little bit hard to catch the Prolene. Then after 4 passes through this loop, this is another way to do the single pass force through technique. And then pulling on the 2 ends of this Prolene, and you will have a good knot, and it's enough to fixate the pupil. But unfortunately, after repositioning this IOL below the iris in the sulcus, I got a pupillary ovalization, maybe due to dilatation or due to the near place of the suture near the pupillary edge. So I decided to do simple pupilloplasty and to do sphincterotomy just to avoid any deformation of the pupil and to overcome this ovalization. And this was the final picture at the end of the surgery. So I prefer to use the same lens than to remove and reimplant another one, as long as I can do this.
Thank you, Dr. Bassem. Sutureless scale fixation of 3-piece IOL also is a valid option for subluxation of 3-piece IOL or in correction of aphakia in general. So Dr. Ashraf Shaarawy, tell us about your experience in Yemeni technique in trauma case. Dr. Ashraf?
I will show you my case. Actually, this is a 6-year-old male patient with history of severe blunt trauma with a horn of an ox. The visual acuity was hand motion, and in the other eye, it was free. The anterior segment, there was a tremulous iris, aphakia, and dense vitreous hemorrhage. And actually, this was the ultrasound of the patient showing dense vitreous opacity with the lens lying on the surface of the retina. The patient went for vitreous, surgery, doing 3-port vitrectomy. And as you can see, the lens is lying on the surface of the retina. And there was a giant retinal break on the temporal side after vitrectomy with shaving of the vitreous base and removal of the whole vitreous hemorrhage. A separate incision was done to introduce the phragmotome, removing the lens from the surface of the retina in the vitreous cavity. And you have to do the ultrasound away from the surface of the retina. Then, can you excuse me for a minute? I'll just reshare the screen. Now, again, vitrectomy. And as you can see, there is a giant retinal break. And the phragmotome is used to remove the lens from the vitreous cavity away from the retinal surface, doing vacuum and then getting the lens into the mid-vitreous and using the ultrasound in 60 to 70% of the power till complete removal of the lens. Now, since the incisions are closed, you have to insert a 3-piece IOL instead of a widening of the incision and inserting of a 5mm lens. Yemeni technique was done inserting a bent 27 gauge insulin syringe, but the lens dropped for the first time and you have to catch it from the mid-vitreous and regaining the end of the haptic away to the sclera. Then going to the other side in the horizontal meridian, doing the same on the other haptic. You have to do it very, very slowly. Otherwise, in a very slow motion. Otherwise, you may get a cut end of the haptic and you get complete drop of the lens inside the vitreous cavity. In a very slow motion, you extract the tip of the haptic of the lens, and then you apply cautery or heat to form a flange which prevents the end of the 3-piece lens to retract inside the vitreous cavity. Now you have to go back flatten your retina, apply laser to the giant retinal break which was present on the temporal side. And as you can see, the lens is very stable and very well centralized in spite of being hanged from the side in Yemen technique fashion. Thank you.
Thank you, Dr. Ashraf. The next stop in our journey is heavy traffic with intraocular foreign body. Penetrating trauma with sharp object usually associated with intraocular foreign body, which may be associated with retinal detachment, and the removal of intraocular foreign body add more challenge to the detachment surgery. So please, Dr. Hassan, let us know how challenge would be, especially if foreign body is large or huge.
Thank you, Megan. And can you see my screen now?
Yes.
Okay. This is a 70-year-old male with a history of car accident since 5 years. The patient underwent somewhere else, actually in another country, cataract surgery and IOL implantation since 4 years. And he presented with marked diminution of vision, unstable IOL, undilatable pupil, and operatively we found an old standing retinal detachment with a large glass fragment inside the eye. This was the picture. And the first step, I confronted a problem because this is a large glass fragment. The edges are sharp and the corners are very pointed. And this piece of glass is resting over a detached mobile retina. So I think the best way is to inject viscohelin underneath the glass fragment. And this helps to elevate the glass fragment and push the detached retina away. And then using a relatively large foreign body forceps, I coat the glass fragment and I pushed the detached retina, which was stuck in a way to the glass fragment. And then with the other hand, I enlarged the another sclerotomy. And because I did not want the glass fragment to fall again on the retina. Once the glass fragment was safely removed, the visco was removed, and then PFCL is injected to flatten the retina. The internal limiting membrane was removed, more PFCL was injected, and then I noticed the presence of anterior PDR, and there was multiple areas of cryo applications, which the patient did not tell me anything about. And then 360 degrees retinotomy was performed, endolaser was applied, and finally PFCL was directly exchanged with silicone oil. The silicone oil was removed the 3 months. The vision, the retina remained stable, and the vision improved from hand movement to 0.1, I think. Okay, this is the case. Thank you.
Thank you, Dr. Hassan. The foreign body may be obvious in the anterior chamber and need special surgical skills to remove it without any collateral damage. So, Dr. Ashraf, Armia, show us the safe technique to remove the intraocular foreign body from anterior chamber without any damage.
This was so weird for me, patient. This patient was a male, a child, 8 years old. History of penetrating trauma to the right eye by gunshot, or as he said, since 2 months. Repaired rupture group was done since 2 months. And he came to me with the pattern of his iris has been changed since the trauma, and his relative said to me that this is not his color of the iris. The vision was barely hand motion, with a good macular function, and his projection was fair. Intraocular pressure was 17 millimeter mercury, and the cornea was in good state. With a shallow anterior chamber, no pupil could be detected on this lamp. I couldn't see the pupil. I did it in my sonar, and the sonar said that there is acoustic evidence of multiple amorphous membranes, and there is an intraocular foreign body, non-metallic, and this is the size. Also evaluated in the plain X-ray, and this is his sonar, and this is the echogenicity of the intraocular foreign body. So I told the patient that I'm going to go, and I don't know where is the foreign body and what I'm going to do. So this is was his picture on the operation theater. This is the old repaired rupture globe. This is maybe the site of entry, and this is another area of trauma. There is a peripheral anterior synechiae here, and I can't see the pupil. So I started the operation to paracentesis, and with a viscocohesive, I am trying to guess how hard is this foreign body? Where is it? Is it attached or it's free? So I felt that this is the area where is the foreign body is. Trying with the, in these cases, don't do aggressive trauma to the iris more than this. Always blunt dissection, very important in these cases. With a visco dispersive, I'm trying to dissect the iris or the membranes from this orange area with more viscoelastic to protect the cornea. I'm trying to remove the membranes and the iris, trying to dislodge this huge intraocular foreign body from the angle with minimal trauma as I can. Injecting more with the Senesky, I'm trying to remove, and finally injecting more visco dispersive. And finally, I got this huge intraocular foreign body dislodged safely with the minimal trauma to the anterior chamber. This was my first step. So now I am removing this huge intraocular foreign body from the anterior chamber. Now I'm trying to deal where is there is a cataract, membranous cataract, residual fibrosis, vitreous. So I'm trying to widen more and more the iris tissue. And then at this point, I wanted to use the ocutome, trying with the scissor first to cut this membranes, because now I found that this is a membranous part. It's not the cataract, and there is no lens. The lens is just totally absorbed, cutting the peripheral anterior synechiae. With the ocutome, I'm trying to remove it. I found it is very tough to be removed by the ocutome. I'm using the micro scissor to cut this membrane to find the pupil. I'm using the bimanual technique to cut these membranes from 2 ports, more bimanual, to making the pupil clear for me. Proper anterior vitrectomy was done and closing the wound. And then after 1 month, this is the picture. This is how it was before, and this is how it is with a vision, with a contact lens corrected up to 660. I'm planning to do a second implantation for the posterior segment was okay. I can see the retina well, and I'm trying to use a second implantation for this child. I am going to use the Yemeni technique for sure. Thank you so much.
Thank you, Ashraf. The foreign body may be impacted and hidden whether in the anterior segment or in the posterior segment. Dr. Bassem, you have a case of hidden intraocular foreign body in the anterior chamber. So let us see your case and how did you suspect its presence?
Okay, this is a case of 32 years old manual worker who received trauma while hammering a nail one day before. On examination, there was a small corneal wound and dilated fundus examination showed within normal appearance of the posterior segment. Actually, there was no apparent intraocular foreign body was detected either in the anterior segment nor on the posterior segment. So, sorry. So this is the video. The idea came to my mind to search for it by the gonio lens. And I succeeded to find this metallic foreign body in the angle of the eye. It's the lower part of the angle. So I opened a corneal wound just opposite to its place and injected dispersive, cohesive, dispersive OVD. And then by the aid of the foreign body forceps and the gonio lens, I removed this foreign body with cautious not to injure the cornea or the lens below me, but it was entangled in the cornea, but it was removed easily by the aid of dispersive OVD. Then re-examination again of the angle to be sure that there is no any injury to the angle like hemorrhage or very minute iridodialysis, and then closure of this small corneal wound by single suture of 9-0 nylon suture and wash of the dispersive OVD from the anterior chamber and closure of the wound and making sure that the wound is well sealed.
So thank you, Bassem. I have also a case of hidden foreign body which was neglected for 6 years, although it wasn't shown by ultrasound in primary surgery, which was traumatic cataract surgery at the time of trauma by one of my colleagues. And after 6 years, he developed siderosis with defective vision, although ERG showed mild affection and the new ultrasound suspects intraocular foreign body. Let's see this case. Now you can see me? Yes, this is ultrasound. This is ultrasound in 2013. No obvious intraocular foreign body, just cataract and just opacity in the posterior capsule here. And in 2019, this is a reaction. This is siderosis, and by CT, there is intraocular foreign body was very obvious. That's why I'm asking at first, we should do both CT and ultrasound, because this case wasn't obvious in the ultrasound, but very obvious in the CT after 6 years. I don't know why. I'm sorry. I don't know. Can you see me or no? Yes. Okay.
Yes, we can see you, but you're not sharing your screen.
This is the ERG, mild affection of ERG. That's although he has severe siderosis and severe reaction in the anterior chamber and the posterior chamber and the posterior segment as well. This is the case. We can see the golden reflex of siderosis everywhere. But this I found this rust, but I didn't convince that it is a foreign body that you are looking for. So during indentation, I saw that something abnormal here. So I suspected the presence of the intraocular foreign body in that area. I tried to dislodge this foreign body. Yes, it's there. I dislodged it, and until falling down, at that time I realized that it was a nail with a large head and tail. I inject a viscoelastic to protect the retina against any falling down. I grasped the foreign body from its head and try to remove it by the second light pipe. I try to make alignments between the shaft of the instruments and the foreign body, but falling down. I think that when I grasp it from its tail, but it was a very bad idea because it's falling down as it stuck to the internal sclerotomy and falling down and make an injury to the retina. So I decided at the time to do bimanual surgery and then grasp the head of the nail with the foreign body forceps, and with another forceps, I hand-to-hand check to make a fitness of the foreign body in the foreign body forceps and to feeding the foreign body with the concavity of the foreign body forceps, and then enlarge the sclerotomy with good grasping, and then discharge the remove the foreign body. As we see this big intraocular metallic foreign body after 6 years of embankments in the global wound. And then I continue my vitrectomy surgery as usual, do laser, and I did silicone oil as usual in traumatic cases, especially in these cases, neglected foreign body. I usually like to do a silicone oil tamponade. This is, let's move to unexpected situation. As we all see in all ocular trauma, we should expect unexpected events during surgery. If you faced with multiple ocular injuries during surgery after blunt trauma, hyphema, for example, vitreous hemorrhage, suprachoroidal hemorrhage, iris injury, subluxation, and so on. So Dr. Wael, what are your priorities during management of unexpected events and situations?
Actually speaking, I usually give the priority to the retina. Yes, can you hear me now?
Dr. Wael?
Yes?
Yes, well, we can hear you.
Dr. Wael, you hear me?
Just a moment. Yes, can you see now?
Yes, well.
Yes, clear, clear.
Okay, very good. I usually give the priority to the retina. Okay, we are ready to avoid a lot of steps in a primary procedure in this situation. If we know that we expect to find a lot of injuries inside the eye, we can postpone some steps to a later stage, because we all know that not everything can be accomplished in one procedure. In this situation, for example, where the patient is a young girl who presented with blunt trauma by an elastic band, a large elastic band that slipped and bumped into her eyes, and she came with hemophthalmos, hyphema, and vitreous hemorrhage and hemorrhagic retinal detachment. I found this as a vague situation because, okay, I will remove the hemorrhage, but I'm not sure what I'm going to find and what may be the obstacles in my way. I usually start in this case by inserting the trocar of the infusion line without adding an infusion line, in case I will do a lensectomy or a fake. Here, the first situation after removing the clotted hyphema was that I found out there is iridodialysis. And I had to make sure there is no vitreous in this area. So I had to hold the dialyzed iris apart until I attempt to do a capsular excess. When I attempted to perform the capsular excess, I found out that this is a subluxated lens. I had to take a decision. So would I focus more on the lens surgery now, or just to do a lensectomy and to focus my attention to the posterior segment, where I may expect to find a lot of things, not only a vitreous hemorrhage. So I performed a lensectomy and I removed the capsule completely, and I entered to the vitreous cavity to remove the vitreous hemorrhage and to inspect the posterior segment underneath that hemorrhage. Of course, the advantage here was that it was just 1 week after the blunt trauma. The hemorrhage looked fresh, somehow partly clotted. This helps me, especially in managing the peripheral vitreous hemorrhage at the ora serrata, which when fresh is easy to manage. Here I could also detach the posterior hyaloid, the bloody posterior hyaloid, and of course, the mainstay here in the management of this situation is to closely monitor the periphery to detect any areas of breaks or residual vitreous hemorrhage. It is essential to dissect the vitreous space carefully in these eyes, and any suspicious area of a laceration or even abnormal tissue around the hemorrhage, I prefer to lase these areas, suspicious areas, and to go for a 360 laser application along the ora serrata, the vitreous space. And there is another point also in this case. You see that there is a severe commotio retinae and extensive subretinal hemorrhage in the retina. I prefer in this case to give the priority to 2 points, to make sure that the hemorrhage wouldn't recur again. And so I injected silicone oil as a tamponade. And of course, at this point, I postponed the idea of having a primary intraocular lens implantation in that procedure. I have to make sure first there is no recurrent hemorrhage and that the retina will stay stable and no development of retinal detachment or a peripheral proliferation, and then come back to a second stage of anterior segment evaluation. That's it. Thank you.
Thank you, Dr. Wael. Rupture of anterior capsule or both anterior capsule and posterior capsule in traumatic cataract is a common finding in blunt trauma. But when we find rupture of posterior capsule with intact anterior capsule, it is unusual in cases of blunt trauma. So, Dr. Bassem, show us your challenge in intraoperative unexpected situation.
Okay, this is a case of 35 years old Down syndrome male. Presented with marked drop of vision in his left eye. By history taking, it was revealed that he had a blunt trauma to his face 2 years ago during an epileptic fit. On examination, the lens was white, fibrotic, and absorbed, and the B-scan showed non-remarkable findings. And I started the surgery usually by doing staining of the anterior lens capsule by Trepan blue. I found it intact and take the complete staining. And I started the rexes. I prefer to start it by, in these cases, by MVR or any sharp instrument. Then the rexes was easy and ended in rounded rexes, as you can see. But surprisingly, as you can see, the vitreous was prolapsing in the anterior chamber through a posterior capsule defect. So I injected a viscoat to tamponade the vitreous. Then by the coaxial cutter of the signature machine, I did the anterior vitrectomy and aspiration of the residual lens matter. Now you can see how is the tear on the left side, and then implantation of a 3-piece IOL in the sulcus. I prefer to put it in the anterior chamber first, then by the aid of Sinisky hook to introduce it in the sulcus, and then to have a good fixation of this IOL in this situation, I prefer to do optic capture. It's very easy to do. And finally, I had injected Mycol to constrict the pupil and removal of the OVD from the anterior chamber and wash of the residual lens matter and closure of the wounds by stromal hydration. And this was the final end of the case.
Okay, thank you, Dr. Bassem. Unexpected events and complications may continue also after uneventful surgery late in post-operative period. So, Dr. Ashraf Shaarawy, let us see how it may happen lately post-operative and how to manage.
Can you see my screen now?
Yes.
This is a 25-year-old male patient with history of loss of vision following hammering with a nail. The visual axis is hand motion. Anterior segment show slit corneal self-wound with posterior subcapsular cataract. And I started doing combined phaco and vitrectomy to extract the foreign body, doing the rexus in the retro elimination using the red reflex enhancer, implanting and the IOL, the lens was seen to be stable. There was a rent, small rent in the posterior capsule, but I thought that this is very trivial and I can put a single piece IOL. I went back and found the foreign body to be stuck in the pars plana in the down and nasal area. Very important, you remove the foreign body by manually, as you have seen in this handshake technique, using 2 instruments, so that you can align the foreign body during extraction along its long axis. So it can be removed easily along the axis of the foreign body. And another important trick is to enlarge the wound liberally, so that you can extract the foreign body without being stuck in the sclerotomy incision, causing problems and falling back onto the surface of the retina, causing problem. And now the foreign body is out of the eye, and I thought that the problem had finished. Hydration of the wound, the lens is centered, the foreign body is out, the retina is flat. And post-operatively, after laser of the site of the impact of the foreign body, the vision actually improved to 6/12. The patient had disappeared for 6 months because he was out of town, and he returned back with a visual acuity of 160 and history of trial of lens exchange by another surgical facility due to the allocation that the lens was subluxated and fold back out of the center. The patient came to me with an affected position, and as you can see, there are sutures in the wound. A PMMA lens was tried to be implanted in the sulcus, so I have to remove this PMMA lens, the C6.5, through an incision. And since I had to enlarge the incision, the decision here was not a Yamani technique, but an artisan with retropupillary fixation, since I had opened the incision to this extent. And you stretch the iris at the start of your maneuver to be sure that the iris can be, that the pupil can be stretched and can be closed. And now the artisan lens is being fixed in the retropupillary space, trying to enclavate the lens at the iris root. As you can see, the enclavation in the retro iris space is very easy, and you have to be sure that the lens is centered in the center of the pupil. And finally, stretching of the iris mechanically to be sure that the lens is well centered and you have no problem with the pupil. And the patient regained his vision 2.4. This case is presented to show that if you have a small rent in the posterior capsule, you go for 3-piece IOL from the start, no need for a single piece, and the affected correction during vitrectomy, primary or secondary procedure, and the use of artisan versus Yamani technique for 3-piece lens fixation. Thank you.
Thank you, Dr. Ashraf. Let's move to the next sub, which is traumatic retinal detachment. The tears related to traumatic retinal detachment may vary from oral tears, macular hole, joint retinal tear, or even dialysis. And the detachment may occur early, immediately after trauma, or late from the onset of trauma. Let's ask Dr. Hassan if traumatic retinal detachment associated with large macular hole. Do you deal with traumatic macular hole like idiopathic one, or you may do something different? Dr. Hassan.
Okay, thank you, Magid. Can you see the screen now?
Yes.
Okay. This is actually it is a 15-year-old. So this is 25. It's 15-year-old girl with a history of blunt trauma since 1 year, and then the girl started to complain of gradual diminution of vision since 3 months. And examination revealed visual acuity of hand motion, posterior cortical cataract, long-standing vitreous hemorrhage, total retinal detachment, multiple star-shaped folds, and a large macular hole. This is the picture at the time of operation. So this is the removal of the old standing hemorrhage. And then I injected triamcinolone, and I did not find any posterior hyaloid. So I injected the brilliant blue, and I started to fashion the eye lamp flaps from different directions in order to close the macular hole with a multi-layer eye lamp flaps. What I call the envelope technique. But as I am doing the eye lamp peeling, I discovered that the posterior hyaloid is still there, and I couldn't recognize it with the use of triamcinolone. But this is how the posterior hyaloid was rather strongly adherent to the underlying retina, and this is expected because of the young age of the patient. So it was dissected to the posterior border of the vitreous base using forceps, and then I tried to move more peripheral, and with the use of the aspiration from the cutter, then PFCL was injected to stabilize the posterior retina. Then I continued peeling or fashioning the flaps in order to cover the macular hole. Dissection of the eye lamp was continued until the flaps could be brought over the macular hole. And at the end, I succeeded in covering the hole with the eye lamp flap, and then I extended the eye lamp peel. I got this free eye lamp flap, and under the PFCL, and again, put some more eye lamp flaps. More PFCL is injected to deal with the retinal periphery, and the posterior hyaloid was still adherent. I could peel it from a posterior to anterior direction, working toward the ora serrata, or the posterior border of the vitreous base, and so that the whole posterior hyaloid could be excised. Now the direct PFCL silicone oil exchange, the hole is closed with the eye lamp multi-layer flaps, and the eye is filled with silicone oil, and laser was applied to the retinal periphery for 360 degrees. Post-operatively, this eye was recently operated. The macular hole is closed. Silicone oil is still inside the eye, and the vision improved from hand motion to 0.60 with correction. Thank you. This is the end of the presentation.
Thank you, Dr. Hassan, for a very nice case. So let us ask Dr. Ashraf Shaarawy, in all the neglected traumatic retinal detachment, is there a rule of electrophysiological test for surgery decision making? And if you decide for surgery, do you modify your usual way in routine vitrectomy surgery in case as you usually do in rhegmatogenous retinal detachment? Dr. Ashraf?
Ashraf left.
I think he has a problem. Dr. Ashraf?
I think Ashraf is not available here.
Okay. Are you,
Ashraf,
can you see now?
Yes.
Okay. I don't think that electrophysiological test has a great importance in dealing with the decision of doing surgery or not, because usually it gives us some sort of erroneous decision. And I will show you in this case, which is a 40-year-old patient with a history of severe blunt trauma, dashboard 1 year ago. The vision is light perception. Actually, he had undergone some electrophysiological tests before surgery, and it showed that the waves are extinguished. And there was no hope for surgery. That's why the patient refrained from doing surgery all that time. He came with total lens opacity with an ultrasound showing total cataract and total retinal detachment. But at that time, the patient was motivated to do surgery. So we went to do a combined phaco-vitrectomy. And as the start, there was a total lens opacity which had dropped immediately to the posterior surface of the retina, removed by phaco-fragmentor. The retina was shortened. After injection of PFC, the PFC had slipped back to the back of the retina, indicating that the retina is extremely shortened. I've played not in full screen because there is problem with full screen. So removal of the cataract by the phaco-fragmentor. And as you can see, the retina is detached with a large break infratemporally. Injection of a bubble of PFC to stabilize the retina, but the PFC had slipped back behind the retina, indicating that the retina was shortened. And at that time, the decision was taken to do a retinectomy. And after taking all the PFC from behind the retina, which has slipped back due to the shortening of the retina, now more flattening of the retina, more injection of the PFC, there was a choroidal rupture in the center of the fovea with a scar, as you can see. But after flattening of the retina and applying 360-degree laser to the edge of the retinectomy and the retina, and doing the laser under the silicone oil, after silicone PFC exchange, direct silicone PFC exchange, I don't go back to air. This is the most safe way to deal with this patient, to do this procedure till the last bubble of the PFC comes back from the surface of the back of the retina. As you can see, this is the edge of the bubble of the PFC going away. The retina is flat and the temporal retinectomy is seen. The patient had his vision improved post-operatively to 260 eccentric, although he had a vision of light perception pre-operatively, and the electrophysiological test told us that there is no hope from the surgery. Thank you.
Thank you, Dr. Ashraf. Thank you, Dr. Ashraf, for this case. In case of bullous traumatic retinal detachment, the difficulties in creating space to work in central vitreous and removal of epiretinal membranes can be managed by finding a space sorry. By finding the tear, by finding the tear or making early drainage retinotomy to drain the central subretinal fluid. So, Dr. Sangeet, do you have another idea or trick to drain subretinal fluid early in order to make a space for working?
Yes, Dr. Majid, I'm going to present another technique by which we do controlled cannula drainage, and I'm specifically focusing on the post-traumatic cases. This controlled cannula drainage is a drainage technique in which we use this intravenous cannula, 26 gauge intravenous cannula, to drain the fluid. So this patient was a post-traumatic bullous detachment, and hardly there was any space for performing any vitreous surgery. So what we do is, so we take this intravenous catheter as far from limbus as possible, and with bevel pointing away, we introduce this catheter inside the subretinal space here. Then we go inside, view that the catheter is in place, and then we advance only the plastic tubing inside and remove the metallic part from the catheter. You can see the subretinal fluid is not coming out. After this, we connect this cannula to the extrusion pump of the vitrectomy machine, and then we can foot control the speed of the drainage. So here you can see, once we start the drainage by the foot control, you see the retina going back. This is another patient. He had a post-traumatic choroidal detachment and an intraocular foreign body. There was hardly any space to perform vitrectomy. Again, this technique was used. You can see this by making a fast drainage. You can immediately collapse all the choroidals and create space. And once the choroidals are flat, you just decrease the speed and to prevent the tissue incarceration. So this is how I generally drain the subretinal fluid or choroidal detachments in a place where vitrectomy is not possible.
Okay, in case of suprachoroidal hemorrhage associated with retinal detachment, do you follow the same technique also, Dr. Sangeet? Sangeet?
Sorry, I didn't get your.
We don't hear you, Sangeet.
Okay, so I'll share another case. So, are you seeing the screen now?
Yes.
I'll share another case. This is a 65 years old female who presented to us 12 days after cataract surgery. And she had with the retinal detachment and choroidal detachment, possibly some part expulsive hemorrhage also. And there was a subretinal heme. So we introduced this control. First of all, we introduced this 26 gauge cannula to drain the choroidals. So you can see a mixture of choroidal fluid and some blood coming out to the choroidals. And once the choroidals were settled, we made a large retinectomy. First, we introduced this blush needle through a very small opening to drain all this subretinal fluid, the bulk of the subretinal fluid, so that it does not overspill into the vitreous and cause the media to get hazy. And once most of the fluid was drained, then we put in the perfluorocarbon liquid to settle the retina. And then do further 360-degree laser treatment and do a direct PFCL silicone oil exchange. And this is 2 months post-op. Patient had regained a good vision of 6/36 2 months post-operatively. So this is how this controlled cannula drainage helps in most cases of choroidal detachment and bullous retinal detachments. Thank you.
Okay, thank you, Dr. Sangeet. I have a different way in drainage of suprachoroidal hemorrhage associated with retinal detachment. You see now my screen?
Yes.
Yes.
Yes. This is the case. This 60 years old patient falling on the ground, vision was PL, total hyphema, ultrasound repeat vitreous hemorrhage, total detachment, suprachoroidal hemorrhage, intraocular foreign body query. So I did for him phacovitrectomy. When I'm doing phaco, I found that blood coming from behind, which indicating how density of the blood hemorrhage behind the lens was. So I finalized my phaco procedures and delayed the implantation of IL for possible exit route for possible intraocular foreign body. I then inserted the 23 gauge cannula inside the vitreous cavity, but I withdraw a little behind to be placed in the suprachoroidal area and just press the valve of the cannula with high infusion pressures to allow for passive drainage of the suprachoroidal hemorrhage in the suprachoroidal area, and then replace the cannula in the vitreous cavity. And then after several seconds working in a fog to remove the vitreous hemorrhage, I found the retina folding upon itself and just attached to the global wall by a small piece. So I deal with this retina as if it is totally a avulsed retina. I flatten the posterior bull of the retina, remove any subretinal hemorrhage, and I do by manual technique to remove the epiretinal membrane using 2 forceps at the edges of the torn retina and in the subretinal area. And I did ILM peeling as I usually do in such cases, but in this case I found the ILM is marginally adherent to the underlying retinal surface. So I removed the ILM meticulously. At that point, I felt that the retina may be torn and lacerated. So I hold the peeling in that at that point and continue my surgery as usual as periphery, doing laser and putting silicone oil at the end as a tamponading. And this is the preoperative picture with PL, and after surgery, and the vision was eccentric 3 meters 0.05 after silicone removal in this case. So let's move. Dr. Wael, if you have traumatic vitreous hemorrhage with underlying giant retinal tear not detected clinically, do you wait for resolution of vitreous hemorrhage or you will go for surgery? When would you operate at first?
I usually try to operate as early as possible because early intervention, whenever possible, whenever that permits, enables the surgeon to manipulate the tissues before the stage of fibrous tissue formation, which makes it more difficult. And in the same time, we may prevent some of the lines of treatment or the management of trauma is to prevent further tissue damage. So in this case, for example, who's a gentleman who were exposed to a blunt trauma while playing football with his friends, he developed a vitreous hemorrhage. And when he presented to me after 4 days with just vitreous hemorrhage. The ultrasound, he performed an ultrasound. I didn't ask for the ultrasound at that time, but he performed it and it showed there is nothing, attached retina. I decided to intervene. And after clearing out the vitreous hemorrhage, I found out that there is a peripheral giant retinal tear. Even though you can see that 99% of the retina is attached. But after clearing out the vitreous hemorrhage and moving to the periphery, I found out, I suspected is that dialysis or a giant retinal tear, but I found out that the retina is extremely lacerated in this area. And once I get close to that part, I found that, okay, so I am lucky and he is lucky because this tear inevitably would have turned into a retinal detachment within a complete retinal detachment within a week or 2. And if I wait for 1 month with the hope that the vitreous hemorrhage resolves, I think he will definitely develop a PVR along the edges of that giant retinal tear. So you see, the management is easy, and the outcome was fine. But if I waited for some time for the vitreous hemorrhage to resolve, I think I would have experienced a more difficult situation, which I will present later in a video after a few presentations. And so I want to focus in this video. My message here is to, okay, intervene as early as possible, and don't underestimate vitreous hemorrhage, even if it doesn't look like a total vitreous hemorrhage or an organized vitreous hemorrhage. It may hide behind it a retinal, a huge retinal tear like this one. And you see that it is a lacerated tear. I had to amalgamate, to mix the breaks, the lacerations into a one giant retinal tear, and to trim the edges as possible as I can to turn it into a clean giant retinal tear and to remove the vitreous hemorrhage. There's another one point here. The removal of a vitreous hemorrhage that is relatively fresh at the level of the vitreous base looks much easier when we do it in the fresh stage. When we wait or when we operate on an organized vitreous hemorrhage, there is usually a problem where I don't feel safe, even if I try to trim as possible as I can from that organized hemorrhage at the level of the vitreous base. And so this is also was another chance that I remove all vitreous hemorrhage and to dissect the vitreous base meticulously as possible as I can, and to inspect, of course, the retinal periphery all around to make sure there are no breaks. So this is the benefit of early intervention in such cases. Thank you so much.
Thank you, Wael. Traumatic retinal detachment with retinal dialysis is different form of different from giant retinal tear, and it can be nicely managed with external procedure like a buckle. But in presence of BVR, the management may be different. So may I ask Dr. Ashraf Shaarawy, there is a rule of vitrectomy in case of dialysis?
Well, I don't think that there is any role of vitrectomy in single detachment or simple detachment due to retinal dialysis. Still, patients can get a very good prognosis by doing just a buckle, as I'm going to show you in this case. This is a patient who had a history of blunt trauma 3 months ago with gradual progressive diminution of vision with a visual acuity of 0.05 and anterior segment was free. This was his detachment with dialysis infratemporal and some demarcation line indicating the chronicity of the condition. He had undergone a simple procedure, chandelier assisted buckling. And as you can see, while depressing the periphery of the retina, you can see the dialysis very clearly. Apply the cryo to the edge of the dialysis very accurately. And you can see the detachment of the vitreous base, the so-called bucket handle appearance, very clearly seen during the procedure. And after application of the cryo, you just apply an encircling 41 band to the area of the dialysis, and you drain the subretinal fluid. And in spite of the fact that the detachment was chronic for 3 months, with some degeneration of the periphery of the retina and the central macula, after drainage of the retina, of the subretinal fluid, the retina went back to its position, and the subretinal fibrosis didn't affect the reattachment of the retina, and the long-term visual acuity of the patient was preserved, and at the same time, you didn't give this patient any danger of getting cataract, and he was a young patient to get cataract and loss of his accommodation by doing any vitreous surgery. Actually, this was after injection of gas and reformation of the globe after drainage of the subretinal fluid. And this was the post-operative appearance of the patient. And in spite of the fact there was lines of demarcation of the old detachment, the retina was attached with good macular function. Thank you.
Thank you, Dr. Ashraf. Sometimes the ocular trauma affects the most valuable area in the retina, which is, of course, the macula, and may lead to macular hole, which may be isolated or associated with retinal detachment. Hemorrhage in the submacular area, or in the sub-ILM area, or in the even in subhyaloid area above the macula. So may I ask the Dr. Wael, in case of traumatic macular hole, what is time of intervention, and if the size of the hole bias your decision making or not?
Well, I think the main point in the timing for intervention for traumatic macular hole depends on the age. In the pediatric age group, we would rather wait for 1 month because there is a chance for spontaneous closure of the macular hole. But for adults, I don't think it takes the same natural history. And so it would be better to intervene whenever possible, as early as possible for adults. The technique is the same for idiopathic macular hole. We usually, of course, we induce a PVD. I like first, I do it like Professor Mortada. I like to induce the posterior vitreous detachment without the use of triamcinolone in the beginning. And I may re-inject again if I feel there is a vitreous casus. But the difference is that I like to perform or to fashion the ILM flap under PFCL. And my rationale is based on the literature which talks about 2 configurations for the ILM in the macular hole. When I do it under PFCL, it takes the style of a pile of sheets. So they are a layer of layers of sheets inside the hole, which makes it more or less more homogeneous and to act as a substrate for a probable mitosis and migration for the Muller cells, which help not only with the closure, but with some functional improvement that may be expected. And the other point that it makes the surgeon quite sure during the surgery and after the surgery that there is no possible retroversion of the flap, and that the flap will always be tucked inside the hole in a flat manner. The trick here is that during the fluid air exchange, the PFCL air exchange, to do it gradually and gently, and to start from the periphery as was demonstrated in the video, from the periphery to the posterior pole until when I'm at the level of the optic disc, I'm quite safe, I feel safe, that once the PFCL is removed, the flaps will not retrovert and there is no risk to get into the vitrectomy port. But more or less, it goes in the same lines as in idiopathic macular hole. Thank you.
Thank you, Wael. Dr. Ashraf Shaarawy, if you have a patient with macular hemorrhage, how do you localize the level of the hemorrhage, whether is it sub-ILM, submacular hemorrhage, or even in subhyaloid area? And if it is in subhyaloid regions, what is the timing of surgical intervention if you want to do it? Or do you think is YAG laser hyalotomy is a good alternative rather than surgery?
Well, I will show you in this case presentation how can I localize this issue before surgery on the OCT, and again during the surgery while staining the different levels of the vitreous and the retina. This is a 30-year-old female pregnant in the 2nd trimester with history of preeclampsia and severe vomiting, and presented with drop of vision in the right eye and teeth. There was a spot of hemorrhage, a big spot of hemorrhage in the center of the fovea, and you can see that at the edges of this hemorrhage, the hemorrhage in part is subretinal, but in some part it's pre-retinal, and there is a glistening cyst overlying the area of the hemorrhage and circumscribing the area of the hemorrhage. With this wall of the cyst very glistening, which is classic of the ILM. So this is a case of ILM, sub-ILM hemorrhage, and I usually prefer to go for vitrectomy. I don't like doing YAG laser hyalotomy, and this is the OCT showing the level of the hemorrhage on the OCT with backscattering on the underlying structures of the retina This is the preoperative still image of the case during the vitreous surgery. As you can see, go for vitrectomy. First, staining of the posterior hyaloid. And you can see very clearly the Weiss ring. And even after you completely detach the posterior hyaloid and the blood didn't move a bit, indicating that this hemorrhage is at a level deeper than the level of the posterior hyaloid. Again, complete removal of posterior hyaloid, still the hemorrhage is encapsulated in front of the fovea, trying to make a hole in the internal limiting membrane using a Thanos scraper or an ILM forceps. There is another part of the hemorrhage at the edge of the cyst, which is subretinal. Finally, a hole is opened in the ILM and all the blood comes out of this hole. The hole enlarged just by using the flute needle as a forceps, detaching the ILM to the periphery, and the blood just in a second floats inside the vitreous cavity, and you remove it by suction and by cutting with the vitreous cutter. And you have to remove the vitreous to the vitreous periphery. And although this patient was phakic, you still can shave the vitreous base since you are doing by manual surgery, and clearer depression helps you to do that without endangering the periphery of the lens. And this is the post-operative appearance. The hemorrhage, which is a sub-ILM, is gone, and the edge of the ILM attachment is still present. There are some patches of subretinal hemorrhage, which clears in few months following the surgery. Thank you.
Thank you, Dr. Ashraf. For this case, I have also a case of submacular hemorrhage in a child with macular hole. Let us see this very short case. This is 15-year-old boy with traumatic macular hole and submacular hemorrhage. Vision was counting finger, and this is preoperative OCT. I did for him a complete vitrectomy as usual with peeling of the posterior hyaloid, and I inject a TPA with a 41 gauge needle in a dose of 25 microgram in 0.1 milli in different sites, and then I did an ILM peeling with inverted flap technique and gas injection at the first with SF6. This is pre and post-operative image with marvelous improvement of the vision up to 0.8 post-operatively. Let's move. Surgery for perforating eye injuries causes severe ocular morbidity with poor visual and anatomical outcome as well. And this may relate to BVR formation, which developed as a result of retinal pigment epithelial proliferation and fibrous proliferation from the wound. So let's ask Dr. Hassan, what do you do in these cases to avoid or decreasing the incidence of BVR formation from inside of the wound of perforating injuries? Dr. Hassan?
Yes, Magid. Okay. Okay, can you see the screen?
Yes.
Okay, this is a 35-year-old male who sustained a penetrating trauma with a gunshot since 3 weeks before presentation. Ultrasound examination and CT revealed that the foreign body or the gunshot is outside the globe. It revealed the presence of vitreous hemorrhage, total retinal detachment, and the visual acuity was hand motion. This is at the time of surgery. This is the exit wound. So I started the surgery with cataract and implantation of phaco and implantation of posterior chamber lens, removal of the vitreous hemorrhage, which was extensive. And after removing the hemorrhage, there was a total retinal detachment. I tried to detach the posterior hyaloid, which was still attached in spite of the trauma and the hemorrhage. and this may be related to the young age of the patient. The posterior hyaloid was removed, and you can see that the retina is fixed in this direction. And there are vitreous and incarceration, hemorrhage incarceration. And this is the site of the posterior exit wound. The pre-retinal blood was removed, and then while the retina is relatively fixed at the site of incarceration, I started peeling the internal limiting membrane. And in these cases, I like to peel the ILM up to the exit wound. PFCL is injected, and you can see how the subretinal blood is displaced. This is the site of exit wound or incarceration. Heavy diathermy is applied to perform chorioretinectomy in order to destroy the tissues and relieve the incarceration of the vitreous and the retina. And this is as suggested first by Zivanovic and then by Ferencz-Kuhn. It is a proactive measure in order to decrease post-operative PVR. And I strongly believe in this technique. After relieving the incarceration and releasing the retina from the incarceration, the base vitrectomy was performed, removing the peripheral vitreous hemorrhage and the vitreous gel, and cleaning the vitreous base. This is how, and I like to cut the retina with the side of the probe. And I felt that this part of the retina is relatively immobile, so I extended the retinotomy to 1 or 2 clock hours to release the retina. The subretinal blood was completely removed. Then laser was applied, and finally PFCL was exchanged with silicone oil. Post-operatively, the retina was attached. There was no proliferation, and the cut and the site of the retinotomy was clean and quiet. And this is the advantage of doing chorioretinectomy in these eyes with a deep impact or perforating exit wound. Thank you.
Thank you, Dr. Hassan. Dr. Sangeet, I know that you follow the same technique. So let me ask first, if the site of perforation near the large blood vessels or near the fovea in the central area, what do you do in these cases? Do you follow the same technique or you change a little bit or modify it?
Dr. Majid, just to start this case, just to show the relevance of chorioretinectomy, I show this case, which is a patient.
Understand the concept of chorioretinectomy.
Young boy who had post-traumatic double perforation and endophthalmitis. So we started with lensectomy in this patient and the removal of the exudates which were present in the anterior chamber. And we cleared the entry wound of all the exudates that were there. Then we sutured this entry wound. So this was the patient who had endophthalmitis. Now we cleared all the hemorrhage and exudates in the posterior chamber also. And once we cleared the posterior chamber, this was the exit wound. It was along the inferiotemporal vessel here, just close to the disc. But 2 months post-operatively, you can see what had happened. We did not do a chorioretinectomy. Large fibrotic membrane which has developed from this exit wound, and which was extending over to the fovea, and the vision was just counting figures 1 meter in this patient. So now case again. So after the second sitting, we removed the membrane along with the ILM. And once we had eaten up this membrane, we did this 100% deep diathermy burns around this exit wound. we spared the major retinal vessels here. We did not do the diathermy over the vessels. Again, we did deep diathermy burns over the choroid to melt away the choroid and expose the sclera below. And we also used vitrectomy cutter to to eat up the choroid and expose the sclera. But again, we spared the major retinal vessels here, did not cut them or try to remove them. Any major bleeding which was seen was again cauterized. Vessels were cauterized from where the bleeding was come, or the bottle was raised to stop the bleeding. Yes. So after this, we injected a short-acting gas. We also did a bit of laser around this chorioretinectomy site. 1 to 2 rows of laser can be done around this chorioretinectomy site. And after this, we did a fluid air exchange, and short-acting SF6 gas was injected in this patient. So again, 20 days post-op, the patient's vision had improved to 6/24. There was no recurrence. And 2 months post-operatively, the patient vision had improved to 6/18. Though there were some intraretinal hemorrhages present due to hair, but it was not affecting the vision much. There was no recurrence seen. Thank you.
Thank you, Dr. Sangeet.
Why chorioretinectomy becomes important in these type of patients with deep trauma.
Okay, thank you, Dr. Sangeet. Vitretinal incarceration may be different from posterior perforation, especially if it's associated with penetrating trauma with sharp object. And I have a case with vitretinal incarceration with sharp foreign body and associated with retinal detachments. Let us see this case. This 35 years old patient with trauma during cutting ceramic edges during his work with ruptured globe and immediate cornea repair, and ultrasound revealed vitreous hemorrhage, retinal detachment, and intraocular foreign body. After working in the vitreous cavity, removing the vitreous hemorrhage, I found a reddish reflex, and at first I suspected that it is an area of clotted hemorrhage, but when I removed the old hemorrhage, I realized that it is a big reddish foreign body. So I enlarged the sclerotomy and dealt with the foreign body, tried to dislodge it from the global wall with the forceps and grasp it with the foreign body forceps, deliver it in the anterior chamber, and with the left hand I enlarged the wound and tried to remove it with the basket forceps, but I failed. I enlarged the corneal wound also as well, and grasped the foreign body with the tying forceps and remove it from the cornea and close the cornea with the sutures. Then return back to the fundus to see what would happen. I found that there is incarceration of the vitreous and the retina, and I manually tried to remove these tissue incarcerated inside the wound. And after removing the old tissue and trimming the edges of the retinal incarcerations and doing a laser around this area of incarcerations and retinal wounds, and deal as usual with a routine vitrectomy for rhegmatogenous detachment. This is my case. Then we shall move. Dr. Sangeet, you have a similar case of vitretinal incarceration with sharp knife. Let us see this other challenge in your case.
Thank you, Dr. Majid. Continuing with the chorioretinectomy cases, this was a patient, 32 years old male patient who had this knife injury during a fight. Ended up with a vitreous hemorrhage with total retinal detachment and a large area of vitreous incarceration. So again, what we did was we first removed the vitreous hemorrhage. We did a complete vitrectomy, including the base excision. After removing the vitreous, then again 100% diathermy burns were given around this vitreous incarceration site, and the retinectomy was done. The retina was totally freed from this incarceration site. After retinectomy, we proceeded with the chorioretinectomy. In this case, we did not remove whole of the choroid, but we created a 1 millimeter bare sclera around the vitreous incarceration site. Because it was a large vitreous incarceration, it was not possible to remove whole of the choroid here. So we just created an area all around this vitreous incarceration, 1 millimeter of bare sclera here. Again, the bleeding that was taken care of by the diathermy only. After this, we did a fluid air exchange to settle the retina. Did a 360-degree barrage laser, and we also did the laser around the retinectomy site. We exchanged air with silicone oil again, and this is 3 months post-operatively. The patient's retina was attached. Silicone oil was removed at this stage, and 1 year post-op, patient had a relatively good vision of 6/36.
Thank you, Dr. Sangeet. If retinal detachment associated with orbital wall fracture with muscle entrapment, especially if associated with impacted foreign body and detraction of the retina around as well. So limitation of eye mobility during vitrectomy add more difficulties and challenge. So Dr. Wael, you have a case similar. So let us see your challenge and how you do this, how you did this surgery.
So of course, we are all focused on the challenges within the retinal detachment itself, especially if there is a vitreoretinal incarceration, and especially if there was a long duration between the initial injury and the timing of presentation. But in this case, I had an additional difficulty that the boy had a deformity in the face due to an extensive orbital wall rupture. And I suspected that I may face the problem that there is muscle entrapment and enophthalmos that may not help me during the tilting of the globe and entry. And I experienced this from the beginning. The local anesthesia for this child produced a lot of chemosis. I had to do a periotomy in the beginning to see well my destination. When I entered at the upper position of the trocars, I found out that it is very difficult. I have to tilt the globe each and every time. So I turned into more along the horizontal meridian. Inside the globe, I found that there is a mixture of combined tractional and rhegmatogenous retinal detachment due to the vitreoretinal, the posterior perforation and the vitreoretinal incarceration, the organized vitreous hemorrhage, and as you see, there is a giant retinal tear of more than 180 degrees. The first task here was to separate the organized vitreous hemorrhage and to eliminate the traction that it produces, so that I would focus on the underlying retinal detachment. I usually use chandelier, of course, in all the cases. My task here was an attempt to isolate the area of vitreoretinal incarceration from the surrounding parts. So I had to, through a bimanual manipulation with the forceps on the left hand, and to use the endodiathermy all around this area of the retina as possible as I can to diathermize and to elevate the infusion bottle so that I would control any or to prevent any intraocular hemorrhage that may happen during the stage of the isolation, and then try to flatten the retina with perfluorocarbon liquid and to check whether in the periphery there is a PVR or not, because the timing between the injury and the presentation was 2 months. And this is, of course, a little bit too long. I found out that it is safer for me to complete the retinectomy 360 degrees and to eliminate any part of the contracted retina to make sure that the peripheral stump of the retina also is completely eliminated. Of course, the tilting was limited because of the muscle entrapment, but I tried as possible as I can to figure things out for myself and to perform a 360 laser retinectomy. The next step is usually, I know, debatable because I like to perform a PFCL air exchange at the beginning and then to do a silicone oil injection under air. But my tip is that I try to keep my probe at the interface peripheral to the retinectomy edges so that I am sure before reaching the edge of the retinectomy and to avoid slippage to make sure that the retina is completely attached. And at the end, I injected silicone oil. Of course, there is some inevitable bleeding despite all the efforts, but hopefully it's limited as possible as we can. This was the best out of it for me. So what do you think? Thank you.
Thank you, Dr. Wael, for this nice case. And we will move to the surprise of ocular trauma. The ocular trauma may be treated with surprise, of course, in either anterior segment or posterior segment as well. So, Dr. Bassem, do you face with surprise in dealing with anterior segment trauma case? And if you have a case, let us show it.
Yeah, okay. Thank you, Dr. Maged, again. This is a case I operated last Friday, a week ago. Is a 56 years old male who received trauma by a wooden stick while chasing a rat. On examination, the visual acuity was hand motion with good projection, corneal edema, evidence of aphakia, subconjunctival hemorrhage with conjunctival chemosis. The AC was deep except for a part of the iris which was adherent to the back of the cornea. CT orbit showed suspected extrusion of the lens, which was seen as a rounded white mass extraocular. So here is the video of the case. I decided to go for exploration under the conjunctiva, 360-degree polyotomy, and the sclera was surprisingly intact. 360 degrees intact sclera. So at this position, I suspected posterior rupture or something like this. So I decided to do reposition of the iris for preparation of the future implantation of secondary IL, but surprisingly, there was a mass moving inside the anterior chamber. You can see the edge of this mass. You can rotate it. You can see the pigments while there is friction between it and the back of the iris. So I realized that this is anteriorly dislocated crystalline lens. It was clear despite the age of the patient. So I opened a clear corneal wound as for extracapsular and delivered this crystalline lens through a corneal wound. You can see how it is clear. Then I did anterior vitrectomy as usual. You can see that the iris now is in normal position. More and more anterior vitrectomy, and by the aid of the triamcinolone to be sure that there is no any vitreous or residual vitreous in the anterior chamber. And finally, I closed the wound as usual by continuous 10-0 nylon suture for preparation for secondary implantation IOL. Thank you for your attention.
Thank you, Dr. Bassem. I have also surprised in different scenario in the posterior segment. Let's see this case. Very short case. This is 11 years old boy with trauma, with a history of diminution of vision. 2 months patient, in history of trauma, vision was hand motions and funnel shape detachments. I plan to do fake lensectomy vitrectomy in this case. and as usual, removal of epiretinal membranes. And after removal, I found that there was extensive intrinsic shorting of the retina. Doing retinotomy, and I found yellowish area, yellowish roads. And when I grasped it, I found that it was a foreign body, and I removed the foreign body through the anterior chamber also. And I surprised because I operated upon this eye as if it is a retinal detachment only. And after removal of the foreign body, when the parents, sorry. When his parents saw the foreign body I removed, they remembered that the child received mild trauma 6 months before with just redness and resolved after a few days. And unfortunately, I opened this eye as if it is an outstanding detachment with closed funnel, and found at the end that it had a subretinal foreign body. Then let's move to last stop, and as usual, in any celebrations, there is fireworks. All of us like to see the fireworks to show in any celebrations, and it makes us very happy to see it. But in some situations, may make someone miserable with its explosions. So, Dr. Hassan, let us see what's going on in your case with fireworks show explosions.
Thank you, Magid. This is a 35-year-old male who was doing fireworks, and all of a sudden, one of them exploded into his face, and he came with this picture. There was an iridodialysis. This was at the primary repair, which is not that good. And there was severe hypotony. So I have to reform the globe, and I sutured the iridodialysis. And because waiting for some time will render the iris rigid, and I think this is the proper time for reconstruction of the anterior segment. Cataract was done, an IOL was implanted, and these are the two pieces of the firework that was found inside the eye: vitreous hemorrhage, total retinal detachment, and as you see, the mobility of the retina is hindered in this area. And at once you have to suspect the presence of retinal incarceration. The hemorrhage was removed. The posterior hyaloid was detached. And until I reached this parapapillary retinal incarceration. Again, the heron was used to displace the two pieces, the two foreign bodies, and one following the other was grasped with the forceps, extracted through another sclerotomy. And then the large sclerotomy was sutured. And then we start to deal with the deep impact wound, because there was another piece that penetrated the eye in this area. Chororetinectomy was performed, and endothermy was applied. I tried to release the incarcerated retina. from the site of incarceration, removing. So it was impossible, of course, to apply more diathermy because it was very close to the optic nerve. But anyhow, I could apply diathermy to the site of incarceration. And actually, this patient is from Yemen, and the patient traveled to his country, and he was followed there by the referring doctor. And I received reports that the retina is attached and silicone oil was removed in Yemen. Then I lost any more information about this patient. Thank you for your attention.
Thank you, Dr. Hassan, very much for these beautiful presentations, and thanks for all speakers. Finally, I want to send a take-home message from everyone, just in a word or in a sentence, for junior staff or other colleagues, starting with Dr. Hassan. Can you tell us as a take-home message in our advice for the junior staff and doctors?
First of all, the timing of intervention. As we said, primary repair should be done immediately. Sometimes it is not only primary repair, but you have to relieve incarceration in the wound, making localized vitrectomy to remove the tract if it is a perforating injury. And then the lens, if it is disrupted, it should have to be also removed. And then give the patient, of course, you have to follow the rules for suturing of the cornea, which should be well coapted. And then you stay, I think you have to wait for 10 to 15 days in order to re-evaluate the condition, perform ultrasound, CT, and also to explain the situation to the patient. The only exception for that is the presence of copper foreign body. Second intervention should be 10 to 15 days. And I think that you have to do all what you should do for the patient, because I don't like to re-operate several times. So if there is deep impact wound, you have to do chorioretinectomy. And I think primary chorioretinectomy is more effective in preventing, or as a proactive measure in preventing epiretinal and subretinal proliferation. These cases are at high risk of developing this proliferation. The retina, the vitreous cavity should be completely cleaned. The vitreous hemorrhage has to be cleaned. The retina should be attached. All breaks should be treated. And I prefer in severe injury to inject silicone oil. It is not necessarily heavy silicone, but inject silicone oil. It gives proper monitoring of the case. You can monitor the case. The visual rehabilitation is earlier than the use of C3F8, for example. And then this patient may need visual rehabilitation. Combining phaco with a vitrectomy depends on the case, the age of the patient, the severity of the condition. So it is not always you have to combine. You may postpone cataract surgery to another session, but iris repair should be done in the same session, because after some time, as Matteo showed us, the iris is atrophic. It's not stretchable. You cannot repair the iris. So these cases need devotion, commitment, and you have to spend much time trying to save this eye. And I felt that all the speakers have the same feeling that every attempt and every effort should be made to save these eyes, especially in the pediatric age group, and in the productive age group. Thank you, Magid, for arranging this, organizing this beautiful and very informative webinar.
It's a pleasure to have you, Dr. Hassan, always. Dr. Ashraf Shaarawy.
Well, first of all, we have to spend a lot of time with the patient and the family of the patient, explaining every bit of the surgery for them and the complication. Trauma cases are open to all the type of the complications, the need for more than one surgery, as Professor Hassan and you, Magid, had shown us that it's open for every intervention, especially with retinal conditions, which have a tendency for reproliferation even after very neat surgery. Again, you have to be prepared before the surgery for all the surprises. You have to be prepared for the different type of lenses for retropupillary fixation. You have to be prepared with the Aman 3-piece lens, because you don't know the situation except actually during the surgery. So it's a very challenging case, not like any regular retinal detachment case. You have to be prepared for the surprises like getting a foreign body, which you didn't pre-estimate before the surgery. So this is one of the most challenging cases of the ophthalmic practice. And I advise my junior to do the surgery in the best circumstances, in the best OR, with the best equipment, and with all the weapons be prepared to deal with the condition. Finally, I would thank you, Magid, thank you, Eva, for this nice, very informative panel.
Thank you, Dr. Ashraf. Dr. Sangeet.
Thank you, Dr. Majid, for making me a part of this program. And Dr. Hassan and Dr. Shaarawy has quite rightly summed up the whole thing. I would just like to add one thing, that because most of these trauma cases are medico-legal cases, so we also need to take care regarding that issue, and we have to make a proper documentation, proper record keeping, and proper consents have to be maintained according to the law of the country, whatever it is, and we have to be prepared for that also. Thank you, Dr. Majid.
Okay, thank you, Dr. Sangeet. Dr. Matteo.
Well, it was a great pleasure to stay with you tonight, and thank you for the invitation. And it's always great to learn from your videos, from your experiences. Every time I learn so much. So thank you. It was my privilege to stay here with you.
Thank you, Matteo. Dr. Ashraf Armia.
Thank you, Magid, for this highly informative webinar. As any case of trauma, the medical consent is very important, and also to tell the patient and the relatives everything in details, because the end result of any case of trauma is not the usual end result of any normal case. As still there is a hope we can reach a safe land with the cases. Also in these complicated cases, you must think twice and always make a plan A and plan B for these cases, and always prepare all your arrangements for your plans. In complicated traumatic cases, always be cool, because you may end in a wonderful result. This is my message for everyone.
Okay, thank
you, Magid, so much, and thank you for everyone.
Thank you, Ashraf. Dr. Wael.
Well, I think everybody has mentioned everything. I would just assert the fact that to hurry up as possible as we can with the primary repair, and as possible as we can with the secondary repair, but not to hurry with finishing all the tasks in one surgery. It is a staged approach. We can take our time in the several steps. The second point is that, yes, we are repairing damaged tissue, but we need to put in mind also during the management to make sure that we prevent further damage or future damage in these cases. Thank you again for being with you all. It was such a great webinar with marvelous speakers and professors.
Thank you, Wael. Dr. Bassem. You are mute, Dr. Bassem. Mute.
Sorry. Thank you, Dr. Magid, for this great webinar. Just I would like to mention that initial evaluation of a patient with eye trauma should be as complete as possible, because decisions about diagnosis and treatment options depends on the initial evaluation. Also, careful history is important, and the visual acuity should be obtained for prognostic and legal reasons. Thank you all, and thank you, Dr. Magid, for this great informative webinar.
Thank you, Dr. Bassem. Finally, my take-home message is any traumatizing eye looks like a surprising package. So I have to have all things ready. I have to expect unexpected events for all cases, even apparently simple cases. I have to have all things. Chandelier should be ready. Bimanual technique should be ready. Everything should be ready. I have to expect unexpected things. And finally, I would like to thank all of you for this enriched, informative sessions, and a special thank to Dr. Hassan, Dr. Ashraf Shaarawy, Dr. Matteo, Dr. Sangeet, Dr. Wael, Dr. Ashraf Armia, Dr. Bassem Fayez. I thanks all of you, and finally thanks to Eva Farm who sponsored us, and hopefully to meet you again very soon. Thank you.
Thank you.
Thank you so much. Thank you so much.
Thank you.
Bye-bye.
See you.
Thank you.
Bye, guys.
Hope to meet you soon.